All right, we'll get started in just a second. For those of you who are here, Chelsea's going to make sure we have your name and the microphone you're sitting at. And let me just say a couple of things before we get started. Because of these mixture of in-person and Zoom meetings, it presents a few challenges. So let me tell you a couple of those. One, when we're presenting online, when someone's presenting online, the microphones here will be turned off. If I turn on the computer audio, then our microphones are off. So there may be a slight delay. So just keep that in mind. We're able to do that fairly effectively. I've chair the Freight Logistics Commission, and we've done several of these meetings, so it works fine, but just know there is a little bit of a delay. Chelsea's going to get everyone's name that's here along with their microphone number. So if you do need to ask a question or when it's time for you to present, for those of you who've not been in this room before, at your microphone, there's a button. If you mash that button, it'll flash on my screen. And again, the numbers in front of your seat don't necessarily correspond with your microphone numbers anymore because we've have separation. So again, just a few challenges that we face in the new environment we're in that we'll work through. So I just wanted to mention those as housekeeping items. And also for those presenters online, and I think Chelsea has talked with you about this, or IT has talked to you about this, you will need to share your screen so that it is able for us to be able to see that. So if you have any questions about that, shoot Chelsea an email or a text during the meeting, and she'll be able to coordinate and respond back to you so we can hopefully have a good, smooth meeting. And we'll get started in just 1 second. All right, we'll get started. And one other quick housekeeping item for those who are online, if you have a question or would like to make a comment, if you would, you can either type that in the chat feature on Zoom, and our house research folks will be keeping an eye on that, or you can raise your hand and he'll try to keep an eye on that, or you can use the raise hand feature on Zoom. Just let him know that you have a question and we'll get to you as soon as possible. So thank you. Again, we'll go ahead and call this meeting to order. I apologize. We had to cancel our last meeting, but we had a tropical storm come through, did quite a bit of damage to a lot of Georgia, and we felt out of abundance of caution and safety that we didn't need folks driving in to the Capitol that day, including staff. So I appreciate your understanding. I also want to mention to you, if you haven't heard, one of our commission members, Dr. Joseph Bona, who was the Chief Executive Officer and Chief Medical Officer of the DeKalb Community Service Board, has passed away. And as a result of that, that was an appointment from the governor's office. Governor Kemp has appointed Dr. Mark Johnson to replace Dr. Bona, and we were able to swear in Dr. Johnson this morning. So he's joining us on Zoom, so he'll be participating in the meeting. So as I'm going to say a quick prayer to start the meeting, and let's remember Dr. Bona's family in our prayers and thank him for his service to this commission and to the state and to DeKalb County. So if you would bow your heads with me. Our most gracious Lord, thank you for the opportunity to gather here, Lord, and do the people's business, God. We pray a blessing on Dr. Bona's family, Lord. In this time of loss, God, we are thankful for his service to this state, to DeKalb County, to this region, Lord. And we pray that his work will continue to live on, Lord. We pray a blessing on all the work that we'll do today, God, that it might be pleasing to you, Lord, and we might take this vulnerable population, Lord, that we're concerned about, and we might find better ways to serve them, Lord. Now bless everything that we do and forgive us, will you, fail, Lord, for it's in Jesus' name I pray. Amen. All right, first up is we're going to turn it over to the subcommittee overview on hospital and short-term care facilities. I want to take just a moment to thank all of our subcommittee chairs and all the members of the subcommittee. They've been doing great work and in some very difficult times. We've had subcommittees that's continually met throughout COVID, many times on Zoom, sometimes in person, and I'm hearing good reports back. Our subcommittee chairs and myself have had some meetings also to discuss progress and to continue in the right direction. So first up, we're going to take on hospital and short-term care facilities, and want to turn it over to our subcommittee chair, Dr. Brenda Fitzgerald, for general discussion. Dr. Fitzgerald.
Thank you so much, and I appreciate the ability to be here. And I want to thank my subcommittee members. They have been faithful and hardworking. And I also want to thank those people that have come before the committee. I've got to tell you that everybody we asked came. Everybody we asked gave us good information. And then when there were follow-up questions, they were faithful and helpful in making sure that we got more answers. What we'd like to do is we'd like to present 3 people that have presented before us. The first one is from a patient's point of view. The second view will be from Children's Healthcare of Atlanta, and that's from someone who sees patients sort of in the emergency room. And then the third presentation will be from Hillside, and that is a receiving facility. We wanted to give you some knowledge about a patient's experience. The first patient it's actually the mother of a patient. This was a video that we got from the Carter Center, and we think it's representative. This mother is not from Georgia, but her child was treated in Georgia. And we think that it clearly demonstrates some of the problems we have in our system. And Emily and Dr. Vall will be in charge of the screen to share the screen with you. So Dr. Vall, if you will begin.
Dr. Fitzgerald, if you can hear me, both online audience and us here in person, it's very jumbled. We're not able to understand what the speaker is saying. I don't know if there's a way that y'all can check that on your end and try to restart it, but we're not able to understand her. We can see her and we can tell that she's speaking, but we're not able to understand it. Your microphone's muted, Dr. Fitzgerald?
Yes, I'm sorry. I said I just sent a message to Emily to quit, and I'll just tell everybody what she's saying.
Okay, we'll leave it in your court. You go ahead.
I'm sorry that this is muted. We will certainly send this out so people can see it in person. But this is the mother of a child who was suicidal. And she had, and this is a mother with means. This is an educated mother. This is a mother who has an insurance for her child. And her story is a story of difficulty getting that child treated. Time after time after time, there was denial of services. Time after time after time, there were situations where she feared for her child's life. So I think that we will send that out in the link that we have accompanying our presentation. That link is included. You may want to hear it, but basically what she says, it is very difficult, even if you have insurance, even if you are fighting for your child, it's very difficult to get services easily. So the next presentation is from Children's Healthcare of Atlanta. And that should be Dr. Dan Salinas, who is the medical director. Emily, if you
Brenda,
could.
Brenda, can you hear me?
Yes, we can.
Hi, thank you. This is Dan Salinas. I'm having a little bit of technical difficulty. I apologize. I want to make sure my colleague, Kristen Cranmer, is in with us. Kristen?
Hey, Dan, I'm here. Can you hear me?
Yes, thank you.
Okay.
Good morning, everyone, and thank you so much, Brenda. As Brenda mentioned, this is Dan Salinas, and I'm the Chief of Community Clinical Integration at Children's Healthcare of Atlanta. And for the past 2 years, I've been involved with the development of children's behavioral and mental health strategy. We really appreciate the invitation to come and present some highlights to a presentation that we did this past summer. We did two to Brenda's committee. So today you're going to see an overview of the challenges that we face as we transition patients that have behavioral mental health support needs to a higher level of care. Let me begin by saying that the emergency room at Children's has become a safety net for these kids in crisis with behavioral and mental health crisis. Let me share some of that data with you. Next slide, please.
It's up, Dan. You may not see it if you're having some technical difficulties.
Okay, very good. So you can see it's been an incredible 5 years. We've had about a 116% increase in children presenting to our emergency departments with a behavioral or mental health crisis since 2015. The majority of those kids are in the 13 to 18 year range. And very significant for us, if we have a child or adolescent in our emergency department that needs behavioral mental health support, their stay is 3.5 times longer than a medical or surgical patient that comes into our emergency room. You can see the top diagnosis, suicidal ideation, depression, anxiety are all connected, and they make up 3 of the top 5 diagnoses. Payer source primarily is care management, CMO Medicaid, and 53% of the children and adolescents we see require transfer to a psychiatric facility. The very significant issue is that 12.5% of those that we transfer end up coming back within 30 days with a behavioral mental health complaint. On this next slide, this just goes over the process, gives you an idea of the process that we use. Any child that comes in, of course, we assess and stabilize. If we determine they need placement, we try to place them. They either have an acceptance, in which case we transfer, or there's a denial, and then you can see there becomes a loop of attempting to place, denial, attempting to place, denial, and that can take days. Some of the factors that affect us, that affect our ability to transfer, are payer source, what have become exclusionary criteria, lab work issues, and consent forms. And I'm going to turn this over to my colleague, Kristen Cranmer, who is Director of Case Management, who's going to share with you some of these challenges we face, and also in the middle of that, depict for you 2 case studies that will emphasize these issues that we face with these transfers. Kristen?
Yes, thank you, Dr. Salinas. Good morning, and thank you for the opportunity to present today. The patient's payer source, if you can go to the next slide, Emily, and that would be great. Yes, thank you. The patient's payer source can present challenges for placement This is because the steps we take to place each patient varies depending on their payer source. So for example, our patients with commercial, private, or CMO payer sources are accepted by most facilities. What this means is that we can initiate placement directly with each of those facilities, and so this process is very straightforward. Our patients with traditional Medicaid can only be accepted at 5 facilities, and if denied by these 5 facilities, the patient can then be placed on the electronic GCAL bed board. Overall, this process is just longer than those patients with commercial, private, and CMO payer sources. And then patients without insurance are our hardest to place because 1, they have no payer, and 2, they must go on the GCAL bed board. If not accepted at a facility after 8 hours of being on this bed board, they are then eligible for a state contract bed. But the requirement of having to make these traditional Medicaid patients wait 8 hours for a state contract bed creates delays in placements. Although patients with traditional Medicaid and self-pay only make up about 26% of our total behavioral mental health patient population presenting to our emergency department, they are the most challenging patients to place. You can go to the next slide. Exclusionary criteria is also a challenge, and overall this criteria presents the biggest challenges we have at Children's when transitioning these patients. Children's follows DBHDD's guidelines on medical clearance and exclusionary criteria for admission. Those are listed on the left there. The exclusionary criteria excludes placements for patients who cannot complete activities of daily living. So these are things like dressing themselves or wiping themselves. Patients who are aggressive and therefore cannot be safely managed at a crisis stabilization unit. Patients who are of a certain age. And most recently, although not listed on the exclusionary guidelines here, is COVID positive status. Until about 2 to 3 weeks ago, we were not able to place an asymptomatic COVID positive patient requiring psychiatric stabilization at any facility, and this includes CSUs and inpatient psych facilities. Now there is 1 inpatient psychiatric facility that has accepted 2 of our asymptomatic COVID positive patients. We also have heard from DBHDD that the CSUs are also working on a plan to accept these asymptomatic COVID positive patients. So that is good news. This exclusionary criteria makes placement extremely difficult for patients, especially for our developmentally delayed patients and for our patients who might be aggressive. For example, there's only 1 facility that can accept patients who cannot perform activities of daily living. However, the 1 facility does not accept traditional Medicaid and only accepts patients between the ages of 7 and 17 years of age. Additionally, if this developmentally delayed patient is greater than 18 years of age, there are 0 facilities in the state of Georgia that will accept this patient who cannot perform activities of daily living. Furthermore, aggressive patients are extremely difficult to place because facilities do not have enough staff to safely monitor the patient and do not get reimbursed at a higher rate to be able to offer a second staff member for that patient. Our autism patients easily meet the exclusionary criteria, as many of them are delayed and unable to perform activities of daily living, and our data supports the fact that these challenges exist in placing patients with autism. So patients in our emergency department with autism and behavioral mental health support needs who require placement wait 15 hours longer in our emergency department than patients with behavioral mental health support needs without an autism diagnosis. We do frequently partner with Marcus Autism Center and our wonderful DBHDD partners on these patients, as they are an extreme challenge for us. If you go to the next slide, this is a true patient example that we had recently, a 10-year-old patient with severe developmental delay, with inability to perform ADLs, history of autism, who presents to the ED. She is aggressive while in the ED, and her payer source is traditional Medicaid. Her severe developmental delay and inability to perform ADLs will prevent her from placement at all CSUs and inpatient psychiatric facilities. Furthermore, because she has traditional Medicaid and autism, there are not any facilities that would accept this child. So again, these cases are extremely time-consuming, utilize several of our resources, and we usually have to get our executive leadership involved to help with the challenges. You go to the next slide. DBHDD's guidelines on medical clearance and exclusionary criteria for admission also require that lab work be obtained for these patients who require placement, regardless of whether the patient's psychiatric condition or medical condition warrants the lab work. This is challenging because the acceptable lab values are not pediatric specific, which causes problems in placement. So for example, patients are flagged as yellow or red, even if the lab value is only 0.05 outside of the acceptable range. So we see this frequently in pediatrics with white blood cell counts that are slightly outside the adult range. We also see this frequently for our pediatric diabetic patients whose blood sugar levels normally look very different than a child without diabetes. So when they are flagged, it causes delays in placing these patients. When a patient is flagged on the GCAL board due to a lab outside of range, a reviewing physician at a crisis stabilization unit is required to review the lab work and sometimes perform a doc-to-doc call before accepting or denying the patient. While the patient is flagged as yellow or red, no facility can review the patient and the patient cannot be placed. If this flag happens on the GCAL bed board during the night or after hours when there is not a physician at one of the CSUs who can review flagged patients, it prolongs the length of stay of that child in our emergency department. We have escalated these cases in the past to Barry Blake with GCAL, who has been extremely helpful in partnering with the CSUs to see what delays, to see how we can prevent these delays moving forward. We have also started conversations with DBHDD and GCAL on the lab values and have provided them with our recommendations for how to incorporate pediatric-specific labs to the medical evaluation guidelines. You can go to the next slide. This is another patient example we had 2 weeks ago. This is a 16-year-old male with a history of bipolar disorder who presented to our emergency department after hours with suicidal ideation. The patient does not have any other medical diagnoses. He receives a 1013 and requires placement at a psychiatric facility for further care. He does not have insurance, so therefore he will be placed on the GCAL bed board. DBHDD's criteria requires us to draw labs even though the patient's medical condition does not warrant lab work. And it's a very common challenge that we experience and one that causes unnecessary lab draws for these patients and delays in placement. The acceptable white blood cell count values are listed on the slide here for you, so you can see the red, yellow, and green ranges. After the labs are drawn, the patient's white blood cell count comes back at 10.15 thousand, which is 0.05 off of the acceptable value. Therefore, he is flagged for review by a CSU physician. And because this is in the middle of the night, the patient will remain in the ED until a physician arrives in the morning to review the flagged labs. No other facilities can review the patient while the patient is flagged. To provide some perspective, our pediatric ED doctors would accept a white blood cell count as normal between 3,000 and 15,500. So you can see how the flags would be quite different if pediatric lab values were incorporated. Next slide, please. One other challenge that we have are consent forms. The consent forms are required by 3 out of the 4 CSUs that accept pediatric patients, and they're also required by several of the inpatient psychiatric facilities. These consent forms are extremely large. Some are greater than 30 pages, and Children's is required to have the parents complete these prior to transfer to a psychiatric facility. Each facility has different forms. Some facilities do not have these forms in Spanish, so you can imagine a nurse sitting at a bedside trying to have a parent read a consent form in English when they are Spanish speaking. Paperwork is frequently lost and has to be faxed multiple times to the facilities. And an additional challenge with these consent forms is that many times for these patients, we do not have caregivers that are with them in the hospital, in our emergency department. So oftentimes this means that we have to ask a parent to either come into the hospital or we have to find a way to get the forms emailed to them and have them emailed back. And this is also extremely difficult for families who do not have access to email or do not have access to transportation to get to a place where they can access a computer. Additionally, for patients in DFACS custody, consent forms must be signed by a DFACS representative. And again, that DFACS representative must come to the emergency department or be emailed the consent forms, and this can lead to delays in placement. Now that you've heard about many of our challenges, I'm going to turn it over to Dan, who's going to share a high-level overview of the differences we see when comparing transfers for behavioral mental health patients versus medical patients.
Thank you, Kristen. Before I go on, I did want to add something. So these issues that we face with exclusionary criteria, lab work, ranges, consent forms, et cetera, and payer source, it's not unique to DBHDD and the GCAL process. We use this by way of example of the patients we showed you. However, this problem exists with the private facilities that we transfer kids to as well. Some of that has to do with staffing, with having the appropriate staff so that they can take an aggressive patient, et cetera, which feeds into this issue of basically of parity. If we have a medical patient that needs placement, which are usually not a lot, we're a quaternary care children's hospital. However, if we do that, we can find a facility that's based on need, similar to a psychiatric facility. We initiate a transfer through our transfer center, and for the behavioral mental health transfer, depending on the payer source, that transfer can be initiated in multiple ways. Physician to physician, nurse to physician. One of our case management assistants can help. It's not as straightforward. On the medical side, there's very little exclusionary criteria. To transfer a patient to a psychiatric facility, you heard from Kristen all the different exclusionary criteria that exist. A medical transfer, our ER doctor speaks with a doctor at another facility, that transfer is facilitated and it goes. On the psychiatric transfer side, it's not as clear-cut always and not as streamlined. Next slide. In terms of acceptance or denial, for a medical transfer, patients are accepted quickly. There are very few denials. I'll give you an example of some of these conditions. We don't have a burn unit at Children's Healthcare of Atlanta, and because that is such a very specific expertise. Fortunately, in Georgia, we have good burn centers at Grady and in Augusta. We're able to transfer those kids or any adolescent female with an OB issue. And remember, because the reimbursement is so different, the reimbursement rates are better, so it's easy to get those patients transferred. On the psychiatric side, acceptance can take much longer, as we've outlined. There are more denials per patient, causing us to have to basically shop around until we find a facility that will accept a patient. And this issue of parity is critical here because psychiatric conditions are often reimbursed at a much lower rate than medical and surgical transfers or medical and surgical conditions. Next slide. In summary, this is what we hope can be addressed during this process. We need a streamlined admission and transfer process. We need for there to be developed pediatric-specific lab testing criteria. We also need a process where facilities will accept and safely care for patients who are aggressive, developmentally delayed, and who are COVID positive. Next slide. Kristen and I are happy to take questions. You can see our email addresses. And now I will turn this back over to Dr. Fitzgerald.
Thank you very much, Dr. Salinas. Now we'll hear from an accepting facility.
Dr. Fitzgerald, before we go on, I think we
Yes.
may have one question from an online commission member. Dr. Johnson, do you have a question?
Actually heard the answer already. I wondered if the aggression was an official exclusionary criteria. I think what I understood is that it's a matter of do they have enough staff to cover, and there's no mechanism to increase staffing for aggressive patients. If that
Yes, Dr. Johnson, you're 100% correct.
Yes.
It is an exclusion criteria because many times facilities don't have the capability. They might have capacity, but they don't have the capability because a child might take a specially trained staff person, or it might take more than one staff person if they're aggressive. And many of these facilities don't have the capability to do that.
Thank you.
And we have a recommendation coming up.
All right, and we have a couple of questions or comments here online. Let me see if I can get Representative Aller. Have you got your button pressed? All right, let's see if you're. All right, try that, Representative Oliver.
Good morning. I'm very grateful that CHOA is coming to the 82nd House District with a new $1 billion facility. Thank you for everything you're doing. I am, keep asking CHOA though, if you're going to change some of your policies to provide your own psychiatric beds and provide more direct psychiatric service for children. Y'all have eliminated your own beds in the past, and keep hoping that y'all will do more on your campus and directly for services. Your percentages are very high in your ER needs for these children. I wonder in your building on your new campus whether you're considering taking more direct behavioral health services approach.
Thank you for the question, Ms. Oliver. This is Dan Salinas, and I'm happy to answer that for Kristen and me. When we articulated our strategy over the past 18 months, we did a deep, deep dive into bed availability in metropolitan Atlanta. We found that there are about 230 beds that can accept children and adolescents in metropolitan Atlanta. So direct answer to your question, right now there are no plans to build psychiatric beds. What we have focused on to get our own house in order is focusing on the care of the whole child. So every child that comes into Children's, we look at their mental and behavioral health status and look at to see if they're depressed, if they have any ideas of harming themselves, et cetera. And we have hired a large number of licensed clinical social workers to provide direct care in our ERs to assess these children. And we are starting to send a lot of these children home with a plan because we have expertise in our ERs that we have developed in order to be able to do that. We also just hired 18 behavioral health nurses to help support our medical surgical nursing staff as we care for kids within our walls. And then we're doing other things in the community. We're training pediatricians on how to care for frontline level type of issues with kids. This next year, we're going to pilot social workers in a few medical practices or in our own urgent care centers who can do some of that frontline care. We're working on a very deep, wide prevention model, and we're hiring leadership staff right now to lead us in this effort. Kristen, anything to add?
No, I think you touched on it.
All right, Chief Deckmore, do you have a question?
Yes, thank you. One of the concerns that law enforcement has is particularly outside of the metro area when there's a difficult or aggressive child or adolescent or adult that is affected by mental illness, but is causing disruption. And the people that should be trained to deal with that don't appear to be trained to deal with it, so they call the police. And what should be handled medically now becomes a police issue. What kind of training statewide would you characterize kind of training that those that are in the ER get for dealing with those affected with mental illness?
It's a great question, Chief. Thank you. Dan Salinas again. The very good news for you all to hear, and I'm sure some of you already know, there's an effort underway. It's a public-private partnership called Resilient Georgia, and our own Dr. Fitzgerald is the chair of that board. Resilient Georgia is committed to making Georgia trauma-informed so that no matter where a person with a condition, a mental or behavioral health condition, maybe known, maybe even unknown, presents themselves, whether it's with law enforcement, at a school, at a church, et cetera, that we all have an approach to be able to care and approach these individuals, trying to determine with them what has happened to them in their past, understanding with them what has happened to them in their past, so that we can begin with them at the right starting point. So I think that is something that's critical and important. And I believe with this public-private partnership that we will have a trauma-informed Georgia. The other thing is, I know that in the system of care, there's a plan for more mobile crisis unit. And those have been started. We probably need more of those. So that's going to be an opportunity for us to have experts that can be deployed right where that expertise is needed to deal with someone in crisis.
All right, thank you. Ms. Skinner, do you have a question?
I do. I believe you said that 30% of the children that come through the emergency room return to the emergency room within a short period of time. Are those children returning from the crisis stabilization units, from their homes, or from the psychiatric residential treatment facilities?
Ms. Skinner, thank you for that question. If I may add, the recidivism rate or the return to the ER rate is about 12.5% over a 4-year period. And those kids return from all of the above. One of the things we are focused on now, though, and we've launched an effort. The majority of those patients are from a Mary group and from traditional Medicaid. So we've launched an effort to take a deep dive, both with the Mary group and with DCH, to understand a large number of these kids have been in a psychiatric facility. So we're also meeting with those facilities to understand. So we handed off to the psychiatric facility. They provided high quality care. The child is released back to the community. What happened? Was there a plan of action that wasn't carried out? Was there a plan of action? Were there resources in the community? Were the resources mismatched with the particular patient? Is this a parental issue? But a percentage of these kids were in a psychiatric facility, were sent home, and then within that 30-day period of all of this happening, ended up back in our emergency room with crisis. So we are focused with these facilities to address that particular issue.
And we have
So just as a follow-up to that, are you making a distinction between the psychiatric residential treatment facilities and acute care and crisis stabilization? I think you said there were 230 some odd beds. Were those the acute care and the crisis stabilization units, or that didn't include the psychiatric residential treatment facilities, correct?
It includes, these are acute beds, so it includes the crisis stabilization units and the private psychiatric hospitals that where we have access for acute needs. It is extremely rare that we would transfer from our facility to a residential facility. It happens periodically. Our biggest need is a facile way to get kids from our emergency rooms to the acute beds. And we are working with both the private psychiatric facilities and the crisis stabilization units to understand why is there this high rate of recidivism back into our emergency departments.
And we have some further discussion coming up I promised you, in just a little bit.
All right, and then I believe we have one more question from someone on Zoom. Mr. Senfeld, do you have a question?
Can you guys hear me?
Yes, sir, go ahead.
Okay. Yeah, I'm hearing from staff often, it's related and unrelated, but as it relates to adolescents, but also adults, that after 5 on Fridays, we're having difficulty with GCAL transferring or even getting acceptance on patients that are in our emergency rooms because there's apparently no receiving physician through GCAL or crisis stabilization units until Monday morning. This presents a huge issue for adolescents, for families, for the emergency rooms and patients that are there, staff, because we're having to hold them for 48 plus hours until Monday when they can be accepted. I just was wondering if anybody can confirm that that's a similar experience. Thank you.
This is Kristen from Children's. We have not seen that problem. We see the issue happening after 5 p.m. on Fridays, but we do typically have a physician that is able to review Saturday morning at some point. We don't know the hours that they are available, so I think for transparency, it would be helpful for I think us to know, and probably you to also know, when the hours of those physicians are, just so that we can set expectations with our staff and our families.
And Wayne, I can give, this is is Brenda Fitzgerald. I can give some insight into that. It certainly has been in the past that there were 72 hours allowed before you got a response. The department has been working very hard on that. So we've been told, and that is no longer, that 72-hour rule is no longer in place. So I think there's been some improvement on that.
Thank you.
All right. The next, and by the
Dr.
way,
Benson, I know you typed something to everyone. Do you want to make a comment?
Sure. So, I've been providing care in the community for the past 10 years. And I think part of what's happening is, children need to be able to get care once they get out, but the discharge planning process is poor. I usually get calls the very day of discharge. I don't get information about what occurred during the hospitalization, why they were put on medications, why they were removed. And so there's a big piece of that transition process that routinely is not occurring in a way that facilitates good patient care.
Thank you, Dr. Benson. All right, Dr. Fitzgerald, we'll go back to you. I believe that's all of our questions for your next presenter.
okay. The next presenter is from Hillside, and Emily Acker, I believe you are up.
Thank you. Okay, can everyone see the screen?
Yes.
Wonderful. Good morning. My name is Emily Acker. I serve as president and CEO at Hillside, and along with me today is Amy Greenblatt, chief scientist at Hillside. As a mental and behavioral health provider, we see firsthand the struggles of children and teens with complex and often life-threatening symptoms. Self-harm and suicidal ideations and attempts are significant in those referred to Hillside. COVID has also played a role in exacerbating symptoms, which has led into an even increased referrals for treatment. The slide shows the various levels of behavioral health care provided for children and teens in Georgia. The services displayed in navy blue are services offered by Hillside. Our presentation today will emphasize psychiatric residential treatment, which sits just below acute hospitalization and crisis stabilization. Psychiatric residential treatment serves as the most intensive residential treatment available in the system of care. It is a medically necessary inpatient psychiatric admission. Hillside serves children and adolescents ages 10 to 21. Our clients typically have a history of multiple emergency room visits, acute hospitalizations, or crisis stabilizations, and most have a significant history of childhood trauma. Self-harm and suicidal behaviors are common in the population served. One adolescent this year had 12 suicide attempts before being admitted to Hillside. Our clients have multiple psychiatric conditions, with approximately 80% having more than 2 diagnoses. Since 2014, Hillside has seen its number of admissions steadily increase from 204 to 450 fiscal year to date. This points to a significant increase in the need for mental health services for children in Georgia. Conversely, Hillside's average length of stay has been declining. In fiscal year 2015, the average length of stay for residential clients was 138 days. By fiscal year 20, we've seen the average length of stay drop to less than 2 months. A client's length of stay is almost totally determined by the funding source, as opposed to the remediation of the client's behaviors or symptoms. One of the primary goals of Hillside's outcome measurement process is to be able to utilize objective data rather than arbitrary medical necessity criteria to determine a client's appropriate length of treatment. We are also currently tracking readmission rates, which are also on the rise. Taking a look at admissions and length of stay by funder, there has been a significant decline in Medicaid admissions since 2014, while commercial insurance admissions have significantly increased. Medicaid length of treatment has also sharply declined, while commercial insurance length of treatment has remained fairly flat. Hillside's payer mix has changed dramatically since 2014. At that time, Medicaid made up the largest portion of children served at 60%. Today, we see almost the exact opposite, where in 2020, 3/4 of Hillside's clients were funded by commercial insurance, followed by 21% funded by Medicaid, and then a few self-pay or out-of-state Medicaid. While referrals to residential treatment for children covered by Medicaid remain high, Medicaid CMO denials for care are 65% of all denials. In most cases, the payer denies the admission based on a loosely defined term, medical necessity. To give you an example of our experiences as displayed in the data just shared, I want to tell you about Rose. Rose is a 13-year-old female with a history of physical and sexual abuse who was sex trafficked by her parent. She experienced 15 acute hospitalizations before being admitted to residential treatment in April of 2019. After residential treatment, Rose transitioned to a foster care home. After 10 months in foster care, her mental health symptoms escalated and she experienced 4 more acute hospitalizations in a 4-month period. After the 4th hospitalization, it was determined Rose needed to return to residential treatment. The first application for treatment was denied by Medicaid CMO. An appeal was submitted and it was also denied. After 2 weeks of collaborative efforts from DFACS, Hillside, and approximately 15 professionals and advocates, a 70-page second appeal on Rose's behalf was submitted to the CMO and finally approved. Unfortunately, Rose is not a unique example. She's just the most recent. How many children have complex treatment needs like Rose, but do not have 15 professionals advocating for their care? In Georgia today, it should not be so difficult to provide a child like Rose the treatment she needs and deserves. Amy?
Thank you, Emily. Hillside has adapted to the increasingly shorter lengths of stay by putting in place an extensive outcome evaluation process that goes beyond what is often typical in mental health treatment. At Hillside, every 2 weeks, clients complete measures that assess outcomes and skill acquisition relevant to the treatment clients receive at Hillside. So for example, we measure a client's ability to regulate their emotions and tolerate distressing negative feelings. Currently, we are using 7 evaluation measures, and to date, we've collected data on 500 clients. With these data, clinicians can see the progression of treatment outcomes and skill acquisition on an ongoing basis. This information can aid clinicians in helping clients to hone and master the skills that are working well for them and address the skills clients need to improve on, ultimately allowing for more precise and personalized treatment. And this is really important given an all too often limited treatment duration, as it can help clinicians maximize the time they do have with their clients. Next slide, please. But the capabilities of these data can go far beyond tracking individual outcomes. With our data, we can conduct analyses to inform length of stay and assess the relationships between length of stay and treatment outcomes. So, for example, as Hillside's data grows, we can use modeling to estimate the treatment duration necessary to produce a clinically meaningful treatment response. Because every child presents with a specific constellation of features and symptoms that are captured by Hillside's measures and assessments, in the future, we can estimate when a clinically meaningful treatment response for a client should typically occur based on their presentation. However, we're all too well aware that the treatment process is dynamic, and this is why our frequent and ongoing data collection is so critical as it can inform the length of stay on an ongoing basis. We can also use the data to compare treatment outcomes of clients who are and are not able to stay in treatment for the estimated appropriate length of time, and we will be able to assess the average amount of readmissions or acute hospitalizations when a client must discharge too soon. In summary, the collection of this data provides a wealth of opportunities to inform treatment and promote optimal treatment outcomes, including the ability to easily assess changes in client outcomes over time, which informs treatment focus and maximizes the limited time clinicians have with clients. The ability to conduct important analyses to estimate appropriate treatment duration and assess differences in outcomes based on length of stay. And importantly, it enables clinicians to provide more personalized and precise treatment. And with that, I'm going to pass it back to you, Emily.
Hillside has adapted its services to provide effective treatment in response to funding and authorization changes over time. We seek assistance in addressing some of the external barriers which exist and are outlined here. Complicated application and prior authorization practices, arbitrary medical necessity criteria for admission, obscure medical necessity criteria for continued stay, and a lack of understanding about the psychiatric residential treatment's role in the continuum of care for children and adolescents. Thank you.
Thank you very much. Are there any questions for the Hillside people before we have our conclusions? All right, thank you. I can say that it was very clear to our committee from listening to the presentations, and the ones today were just an example, that if you look at hospital and short-term care, it's not just a matter of throwing a bunch of money at it and having more hospital beds or increased insurance coverage. That certainly may be needed, but much more important, we felt, was an understanding of what we're using now, of what we have now, and an accountability system so we could follow progress. We needed information. Emily, if you will put my slides up. We can tell you that nationally, Georgia, as far as access is concerned, and access involves the number of people insured, the number of people who get treatment, or the number of people who do not get treatment, and the number of beds. So it includes all of those issues. And Georgia is ranked 50th and 51 because DC is also included. So it is ranked 50th out of 51. To give you some context, Alabama's 46, Florida's 40, South Carolina 47, North Carolina 44, Tennessee 42. So obviously there are a lot of states that are in this situation, but certainly Georgia is top as far as concerns. One thing that we thought was pretty clear about listening to the testimony that we had is that we can solve, we think, unnecessary admission delays pretty easily. It's pretty straightforward and really would require a very small amount of money. One is the whole question of aggression. You saw from the slides at Children's Healthcare that the number one reason for exclusion was aggression. So we believe that we should add an aggression amount of money so that those receiving facilities can hire the staff that are trained appropriately to handle children who are aggressive and ensure patient safety. We think that should be done without delay. The second thing is we understand, we think it's a big problem about not being able to talk to a physician and a physician not being able to review these exclusionary measures. We suggest that we have funds for a 24-hour physician, and we don't think it needs to be at every crisis stabilization unit. We believe that the crisis stabilization units can come to an agreement that there be one physician on call for all of them, and that can greatly decrease the amount of time that patients are staying in emergency rooms and not getting the care they need. 3, the GCAL board certainly has improved. 1, it now allows electronic information. You don't have to simply call and wait on the phone until somebody can answer. Also, they've gone from a 72-hour response period to a much lower response period. But if they can allow more than one facility to review a patient at a time, rather than having somebody be presented to a unit, that unit having a period of time, whether it's 8 hours or 72 hours to turn them down, and then the second person review, that seems very inefficient to us, especially since, as you've heard from multiple people, that there are exclusionary challenges at various facilities. And then 3, and the last one is, we believe a universal consent form. If you have a 30-page form, if you have multiple forms, we think surely a universal consent form can be arranged by crisis stabilization units, and that those need to be certainly in Spanish in our state, English and Spanish, and also they need to be electronically, have the ability for electronic signature. This will solve a lot of problems. The problem of consent forms being lost, the problems of if somebody's in an emergency room and is not admitted, say for 24 hours to a facility, then by the time you get the consent form signed, there may be nobody to do it. It just makes sense to us that there be a universal consent form with electronic signature available. Next, please. And I want to point out a couple of things that are of concern to us. One, if you look at this decrease in the length of stay, and next, Emily, the next one. And if you look at this, we looked at the number of patients who were sent from the emergency room and who returned back within a month. And we went back and we asked Children's Healthcare to provide us with the different plans that were involved. And you can see, for example, that Cigna has a 1% of patients that were covered by Cigna returned to the emergency room within a month. While Amerigroup and traditional Medicaid had 1/3 of the patients that were sent to facility return within a month. There are 2 things I want to say. One is, after we received this information, the members of the committee talked to the medical director of Amerigroup. It was a very positive interaction, and there are several things, like Dr. Benson suggests, that maybe they're just the review process or the follow-up process on when you leave a facility may not be ideal. So Donna Hyland, who is a member of our group, has agreed, and the medical director of Amerigroup have agreed to start a discussion group to bring further information and insight on what we need to do about these children who are revolving. But it still raises the question of denials for length of stay. And are concerned that we really need a process in place so that we make sure that the decisions made are 1, the correct decisions, and 2, we have a way to track that. So the next discussion, if you'll show the next slide, Emily, is a whole question about the Georgia Parity Law. There are, in our presentation, you will find Appendix A, which comes up with a model Georgia law, Appendix B, which comes up with a model Medicaid law for Georgia, and Appendix C, which shows the states that we reviewed. We have 5 states that we recommend We reviewed, and those states, by the way, are Arizona, Indiana, Oklahoma, West Virginia, and Texas. And that we asked the Legislative Counsel, Betsy Howerton, to review, and the comparison of those are in there. So we think that we have really done, the committee has done its homework on looking at this whole issue. We do not, David Lloyd, first of all, we heard from him. He is he is a national expert, is his senior policy advisor for the Kennedy Forum. He is the person that talked about, even though there is a federal law, the federal law for parity of behavioral health and mental health, behavioral health and physical health, that was passed in 2008. And then a second law that was passed in 2016, which included not just commercial insurance, which was the first one, but included all Medicaid coverage, and that was passed in 2016. So we heard from him, and that is the national organization where we got our recommendations for which states to look at. We wanted to look at states that were similar to us, and we also wanted to look at states that had made progress. We then talked to, from Tennessee, Mary Linden Salter. She is the person at the state of Tennessee who was responsible for, once the law was passed, the realities of it. Tennessee has agreed, and we certainly have lots of other states who have made progress that can give us help in the realization once we pass the law. And then 3, the sample legislation, there's an organization in Georgia called the Georgia Parity Collaboration, which is 20 nonprofits who are interested in the whole business of behavioral health. And we heard from them and their recommendations for what they thought would be a good law as far as Georgia is concerned. The most important part, so those appendices are included with our report. But the most important thing about all of them is that we really don't know the numbers. We know that NAMI has reported that 2 times for behavioral health, there are 2 times more behavioral health denials than physical health denials. We certainly had the information from the facilities we looked at that denials are occurring. We do have information from other states. Illinois, for example, looked at other states. And just like our state, or just like Hillside reported, they reported that 59% of inpatient admissions were denied. They also reported that medical necessity was a problem in their state for 27% of the time, often, and 6% of the time for their providers, always, with their Medicaid providers. The other problem has to do with networks being closed. They reported in Illinois when they did their survey that 63% of the time they were told that the networks were closed. And even more percent of the time, 72% of the time, there was difficulty to join a network. So we think that this information needs to be made available. The Department of Insurance has the power to ask for information from private companies, and Department of Community Health has the ability to ask for information from Medicaid companies. We think that we should have, on a yearly basis, reported to the governor, the General Assembly, the Commissioner of Insurance, and this task force, as long as it is in place. And that should include, 1, the number of the mechanism for prior approvals and the mechanism for medical necessity. That's important that that be identified. 2, when there is denied medical necessity, we need to track that. We need to know when the denial of length of stay occurs. We need to track the return to all emergency rooms and or admission facilities. We need to track the number of times it is difficult to join a network, and we need to track the number of times it says the network is closed. With this information, I think that's a more important point. I think we can quickly make progress to some of these concerns that we see presented on a fairly uniform basis. The other thing too, though, needs to have to do with what the public knows. We want the Department of Insurance to have market exams for compliance. And also we need to know that there's transparent and easy public consumer complaint process. Right now, that is not so. We think there needs to be a designated web page where, when there is a denial, patients can go there, and also patients can find out, can track their complaint, because that does not exist at this time. Certainly, Department of Community Health, and by the way, they have been very helpful to us and responded to us and spoken to us, but we certainly want to make sure that they are clear that parity requirements in renewed Medicaid managed care contracts. And to do that, they need the information that we listed as far as what we should be tracking. Next, Emily. On the way, by the way, these are testimonies that we heard that would be applicable to other workforces, and we simply wanted to share what we heard. And one is that there is no database that tells what behavioral health providers are available. Emergency rooms do not have that information. Most behavioral health professionals are relicensed every 2 years. When they are relicensed, we suggest that that form includes their certification specialties, their locations, which insurances are accepted, and if they offer telehealth. If we have this information collected, then our technology group with this task force can make it easily available that when an emergency room needs to refer, or when a crisis stabilization unit needs to refer, or when an inpatient facility needs to refer, those resources that are available for referral will be easy to obtain. We certainly heard when we heard from Georgia Medical Association, that most, especially those emergency rooms in the rural part of the state, do not know which outpatient facilities are available, which insurances they cover. And we had that also confirmed by a large hospital in Atlanta, that they simply didn't know who was available. So this data set needs to be accumulated, and it can be, the upkeep can be certainly every 2 years, and that will be an ongoing process. The second testimony we heard that we want to refer to the workforce group is that licensed marriage family therapists and licensed professional counselors cannot be independent providers. What that means is, if their patients come into an emergency room and, for example, are suicidal and need to be committed, these therapists cannot sign a 1013, cannot make recommendations. And we have, when we look at the workforce shortage, licensed marriage family therapists, for example, there's a lot of training of them that goes on in Georgia, but the vast majority of them leave Georgia. So we will share our information with the workforce group again, that we believe that it would be a fairly straightforward way to increase the number of professionals that we have available. Next, Emily. And the next thing we heard is about telehealth. One, with COVID, the one positive thing we think is that it has become clear that telehealth will work. And we want to encourage the legislature to carefully look at those facilities that have been offering telehealth services and maybe make them permanent. DOAS is now in the process of evaluating telehealth contracts for the school system. And this would be a statewide contract that looks at those companies that can provide behavioral health services that are HIPAA compliant, that have the ability to do it all over the state. And we think we want to encourage that because we think that that could again be a way to solve the access problem as far as workforce. And the third thing we want to bring to your knowledge is that it's called the ECHO model. And that is a model where there is not just telehealth, but there's a partnership between, for example, those folks in South Georgia who may not have a specialist who deals in traumatic brain injury. So there is a way to share very specialized information throughout the state. The Georgia in Albany, excuse me, the Georgia Rural Health Commission, I'm sorry, is now in the process of becoming a ECHO hub. And we, again, think this is a way that we can rapidly get services we need to those places that do not have services. So our last slide is the list of the people that we have talked to. We want to again thank you very much for all these people who talked to us. You can look at our again our general idea of the status of behavioral health in Georgia. Appendix 1, Appendix A is commercial insurance model program, model law. Appendix B is Medicaid. Appendix C is a state review. Appendix D are the people that we talked to. And the last appendix, all the data that we have, for example, from the various organizations are in that part, and you can tap on it and you can look at all the information that we have collected. So thank you very much. And we are certainly open to questions.
Well, Dr. Fitzgerald, I want to thank you and your subcommittee because y'all have done a tremendous amount of work, meeting numerous times in person and electronically, taking a lot of testimony, a lot of information, and obviously I think it's evident that you have put along with your subcommittee a lot of thought into your recommendations. So thank you very much for that. We do have a few questions. First, I believe, Ms. Skinner, do you have a question?
I was wondering if you had included in your data on the children that are coming into the emergency rooms or into children's health care in particular, are you including substance abuse disorders in that data, or is that simply mental health?
This is Dan Salinas. I'm happy to answer that. The number of kids we see with substance abuse disorders is relatively small in our emergency departments. So it's a very rare diagnosis for us. So in general, it is not included. There are not a lot of cases included in our data.
And then a second question, the readmits that you spoke of, were those, do you have information about how many of those or what percentage of those were for suicidal ideations or actions?
I don't have that data in front of me. Kristen, do you know that data?
We can get that data for you if that's helpful. If you give me a few minutes, I can send it to you via the chat box. It is our top diagnosis, though, for all of these visits to our emergency department.
which then is of particular concern if they're not being placed into the appropriate treatment. So thank you.
Sure.
You're absolutely right. And the interesting thing, we did not report on because we haven't finished our work on, but we're very concerned. The first parent that spoke about her child's repeat suicide attempts. And so we know that is a big problem. The number one reason that comes to the emergency room that we have seen is suicide attempts. So that is a big problem. And there are also some, quite frankly, some waiver problems that have to do, that we will look at, but we're not prepared to offer now. And that has to do with some testimony that we heard. If, for example, a pediatrician sees a child for a routine exam, and during that time, the child says, I'm going to kill myself. That, under our current Medicaid federally, not Georgia, but federally, two visits cannot occur on the same day, or two visits cannot occur in the same location. So what that means is there's a problem if a physician sees someone for a routine visit who says, I'm going to kill myself. Immediate follow-up is very difficult to obtain. So you are right. We are concerned about suicide, and we have some ongoing work with that. We're not ready with those presentations just yet.
Brenda, could I add something to what you said? Is that okay?
Absolutely.
This is Dan Salinas again. We just took a deep dive with public health, and they did a phenomenal job using syndromic data to look at our admissions to our ER for suicide ideation or gesture or suicide attempt. The reason we did that is in a 10-day period in October of this year, we had 59 children that presented to our ERs with suicide attempt, primarily by ingestion, suicide ideation, or gesture, which is not an uncommon phenomenon in the fall. So this is a very critical issue. I was able to get with Dr. Toomey, and we used a provision that allows public health to get into the medical records, and they did a really deep dive. Some of these kids had been seen in the prior 6 months for other similar conditions, not necessarily suicidality. So the good news is we've got good data. Public health is on this, working with us. We're going to get to the bottom of this. We want to get to where we understand near misses around suicidality so that these kids don't come in with an attempt.
All right, thank you. And I believe Representative Oliver, you have a question.
Thank you, Mr. Chair. I would like to have a copy of your slides, if I may. Thank you. I'd like to, somebody today, not necessarily right now, clarify for me the different information I've gotten as to whether the GCAL line is open on the weekends or not. I've heard it two different ways, I think, this morning. But my real concern is really trying to understand. I'm confused. I should know the answer to this, but I don't. What entity exactly is denying the access to residential care? I'll use Rose as an example. Is it Amerigroup, or is it the Medicaid entity that's denying that access? And is it different depending on whether a child is a foster care child? That has flipped the percentages of children who are receiving residential care dramatically from what I thought it used to be in terms of who's getting care. Medicaid children today not getting care, private insurance children getting care. Where's the denial happening?
What we think is we ask Hillside to give us that by payer group, and they are looking at that specifically for when denial of care is occurring. My understanding is we don't have a good handle on, and that's what we are suggesting. We do need a good handle on who exactly is denying care. especially, you're right, about AmeriGroup. We know that testimony we have from the DFACS, from foster care, is that they are spending an additional $50 million on behavioral health for foster children. And that is a question that I think we absolutely need to look at. But what we need to do, I think we need to immediately ask that these questions we're asking about denial of care, so that we have those reports, so that we look at it. We don't have that information in Georgia now that I've been able to obtain. But you're right, we need it.
All right.
And that was our
Commissioner
recommendation.
Fitzgerald, you may have, so you want to come up, and you're a member of the commission, just grab a seat. And if you don't mind, just mash the button in front so I'll know which microphone to make hot. Yeah, wherever you want to sit, it's fine, Commissioner. Yeah, things are a little different here than they usually are. Just mash the button if you don't mind. It's hard to know which microphone is. Try
That work?
That's
Yeah.
it. You got you.
I'm happy. I don't want to override anyone else's, but I can answer two questions as directly as possible. One, very importantly, to the GCAL question. GCAL is 24/7, 365 days a year. No question about that. If there ever is a question about that or a concern, I would love to know that. So, and then to your second question, I think the most direct way to answer that as a high level is what happens for any individual depends on their insurer. So it is different if a youth is in DFACS because their insurance is through AmeriGroup. So another kid who's having what look like similar challenges, but they have a different insurer, whether it's the state or a private insurer, their access would be different, and it's dictated by their insurance plan for the DFACS children.
And what percentage are we talking about are defects children for these denials? I mean, I'm looking at the circles, that she was showing us that show the denial, which was before you came in.
Yeah, I saw some data up there, but I'm not quite sure what the universe was.
Medicaid children is what was being denied services. And I guess my question is, what percentage of those Medicaid children are AmeriGroup? And how does it break down? AmeriGroup denies 50% and Dr. Berry denies 50%. That's what I'm trying to figure out.
Thanks, I understand that. The Department of Community Health would, that would be their data. So, and again, I'm not sure what was shown, but just to be clear where that data set is from.
Dan, if you're still with us from a children's healthcare perspective, I believe you showed a slide that had the percentage of breakdown of denial between the different providers. Can you answer that question from children's perspective?
Let me take a look, Mr. Tanner, one moment.
And Dan, I'm not sure we have denials. We have started to create a process for tracking denials by patient, by payer, because we are not able we just don't have another way to collect that data. Dan, I don't know if you have anything else to share on that.
No,
Exactly.
what you all saw in slide 2 was payer sources, actually, of the patients that come to Children's over the last 4 years. And from payer sources, the majority of our patients that come to our ER with these conditions are part of the care management organization, CMO Medicaid, 51%.
But I think, Representative Oliver, the exact question you want to know, we want to know too. That slide that's up in front of us, those are the children that have returned to the emergency room. So we don't have a good grip on those questions about denial of care, and that's our recommendation, that we start looking at that, and then it'll be clear, and it'll be clear how to solve that problem.
All right, I believe Chief Deckmore, you have a question.
Do. With regard to denial of care, is that something that can be addressed legislatively or through the Insurance Commission, that when similarly situated children with the same diagnosis, one gets treatment, one doesn't? And then historically, looking at the data, is that denial of care responsible for the reentry to the emergency rooms because they're, they continue to have chaotic episodes?
Commissioner.
Yes, we believe that may be the
You're
case.
asking really good questions, and that's important. I think, again, at the simplest level, what I could say is there are a number of reasons care could or would be denied. And it's important to do that next level of dive, because a clinical denial of care is different than an administrative denial of care. You can guess what those are. A clinical denial would be, we look at this clinical information about the presenting youth and say, we don't think they need what you're saying they need. An administrative denial would be, I'm oversimplifying here, but you didn't give us enough information, right? Or the information is incorrect, not, box is not filled out, it doesn't match, whatever administrative things you can imagine happens in all of our insurance lives. So I think this question of when denials are, so you see these denial numbers, I think it causes all of us concern and we say we want to know more. I think the right thing is to say, let's know more. What kind of denials are they? What are the circumstances they're happening? Or, do we as a state ultimately believe that the situations where youth and others are presenting, do we think these are things that should be covered? And at what cost? And do we all understand when we say, open that up, what we mean? Are we all willing to do that? And I know this group is as passionate as I am about when you hear these stories, particularly when they're about youth, we want to say, what can we do differently? We think kids need access to the level of care they need. And in the end, we know that saves money, saves lives and saves money. But it really does require a deeper drill down into that data about what's actually happening.
And I think that's one of the things that the subcommittee was talking about, is a lot of that information, we just don't have the answer to it, but we need to set the mechanism in place to obtain it. And then the other thing I think I heard them talk about was the Department of Insurance having an easier process to appeal those things. And when they are denied, to make sure there's transparency and a parent feels like they have a mechanism in place.
Well, it's just concerning to me that if people, whoever, the advocate is for this individual or this child, if they engage a couple of dozen experts, then they're going to prevail. If someone less sophisticated or without so just the crapshoot nature of it, I think, is the concerning aspect of it. But thank you.
Thank you.
We agree.
Ms.
And
Skinner.
therefore, that's the reason we said we
Go
want.
ahead, Ms. Skinner. You've been recognized.
Sorry.
I think also you have to remember that there is denial to treatment, and then there's denial of continued treatment. And so those are two issues. And if you're looking at the data about children, then you need to look at the length of time that they're allowed to stay in treatment, and then what are the outcomes for those children. Is longer better? Or are we missing the boat because we are denying treatment too early for them? Because we often don't regard things like they may be in a psychiatric residential treatment facility, and education is a very big component of that, because you want kids to be successful in school also. And discharges based on their mental health, and not necessarily when it makes sense for them to end an education session and begin the next one in a logical, orderly manner for that family and child. So there are a lot of things that play into it. But if we're looking at denial of treatment, then you also have to look at denial of initial treatment and denial of continued stay in treatment.
All right, Dr. Fitzgerald, I believe online.
Yes, we absolutely agree with that. And that's why when we made our list of things that should be immediately available and available on a yearly basis, one is the denial of treatment, and then for the reason. We want to know if it's medically considered medically unnecessary, how often that occurs. We also want length of stay, and we want those children that return to some form of care. We want to track all of that because you're absolutely right. Unless we track this in its entirety, we will not get the answers we need.
All right. Thank you. Thank you, Dr. Fitzgerald, and to the Hospital and Short-Term Care Facility Subcommittee and all of our presenters today. Also for the members, Chelsea will be emailing out all the slides and all the information to you later today for Dr. Fitzgerald and all the presenters. So you will have that electronically, and I believe she handed out the appendices that we were being referred to. All right, next up is Ms. Skinner with the Subcommittee Chair of Workforce and System Development. I want to take an opportunity to thank her and her subcommittee for all their work, and thank them for everything they've done. Look forward to hearing from you. Chelsea will get you up and running. After Ms. Skinner finishes today, we will have lunch for the members that are here. We're going to do a working lunch. So after Ms. Skinner's presentations, we'll take a short break, and then we'll have a working lunch and continue forward. So thank you. Before we get started, let's just make sure that everyone online can see the presentation. Can some folks online just give us a nod or a thumbs up? Or all right, good. Everyone can see it. Sorry about that, Ms. Skinner. Go ahead.
Chairman Tanner, members of the commission, I'm Gwen Skinner. I'm the operations vice president for Devereaux, Georgia, Florida, and Texas. And in Georgia, that means that I also serve as the executive director of a psychiatric residential treatment facility for children and young adults. My members of my subcommittee are Sally Koch with the Georgia College, Cindy Levi with the Vita Community Partners, Representative Mary Margaret Oliver, who's with us here today, Dr. Nicoletta Sorbonne with Georgia Tech, and Senator Renee Unterman, and we've been busy. We looked at what was our process going to be, and this looks very simplistic, but we thought that we need to look at a review of the previous commission and study reports and literature that's available, that we were going to have presenters, that we were going to make data requests and do some analysis, do some of our own analysis with Georgia Tech on the data that's available to us, and then make some recommendations. There have been a lot of behavioral health commission and study commissions, and this just gives you those. And I'll have a recommendation related to that later on, but this just began. We just started looking at those from 2007 forward. And all of these commissions and study committees have made recommendations. This is the literature review that we conducted. We looked at states who we felt like were making progress in this area and had taken a serious look at workforce development and what it was going to take in their state to move it forward. So this is just our literature review of that. And so here were our key findings. We know this even from our previous discussion, that many individuals who need treatment do not get it. When you talk about workforce, the reason they do not get it is either we have an insufficient size of our workforce, we have frequent turnover. You have only to work in a psychiatric treatment facility to experience turnover. And I'm sure that Commissioner Fitzgerald could tell you the same thing about our state facilities. We've got lower compensation for people in behavioral health. which is an issue. We have minimal diversity, and I think that's something in my own organization that we are trying to take a serious look at, because when you look at facilities and you look at your lowest paid staff, then you're looking primarily at minority workers. And so what does that say about the value we place on the work of direct care staff and the role that they play? And so we also think that there's limited competence in evidence-based treatment. That doesn't mean we don't do evidence-based treatment in Georgia. We do. And in fact, have been a leader in some areas, but it's not universally available across our state. We found that salaries for behavioral health professionals are well below comparable positions in other healthcare sectors. And because of that, you can talk to a lot of the psychiatrists, and they're in the business because they are mission-driven people. They will tell you, I could have made more money if I had just turned left instead of right, but I made a decision that this was my interest. It's something we have to look at. And then we have health professions that have scopes of practice that overlap with one another, and that we may be able to make some adaptations in Georgia that will help increase our size. Key findings: Nebraska, New Mexico have got legislation that allows them to collect, analyze, and disseminate information about their behavioral health workforce. That includes looking at their workforce trends, identifying priorities for the future. Georgia has a similar program, but right now we're only using it to collect that kind of information on physicians, physician assistants, and nurses. Then there was a report card regarding mental health parity across the states. And again, there is disparity in provider reimbursement levels. And you can see, and I'm moving what I've got on my screen. You can see in Georgia, the rate for primary care is 38% higher than the rate for behavioral health care. Has to be addressed if we're going to move our state forward. And then in February of 2020, the Massachusetts Senate passed a bill to help support mechanisms underlying parity. So that included expanding the mental health practitioner workforce and seeking a rate floor to ensure that mental health clinicians and primary care providers are paid similarly for similar services. The most comprehensive effort we found to address behavioral health workforce issues was conducted by the Annapolis Coalition on the Behavioral Health Workforce. And that was funded by SAMHSA. And they proposed a framework that we adopted for our subcommittee's work. It focused on broadening the concept of workforce, strengthening the workforce, and then creating structures to support the workforce. So that was our framework when we looked at it, that we agreed these were the things that we wanted to address. So we had presentations by agencies and people that we considered experts in the area. Dr. Erica Sitkoff with Voices for Georgia's Children. We had from the department, we had Dante McKay, who's the director of the Office of Children, Young Adults, and Families. And we also had Brianna Kelly, who is with the department, and she is their autism project coordinator for the Division of Developmental Disabilities. In addition to those, we decided we needed to hear about Georgia's Board of Healthcare Workforce, because that's where we thought we were going to be able to get data about our behavioral health workforce. And that's where we found they're doing really good work, and we're very open and very candid. They just don't track on behavioral health workforce. And then again, we brought representatives from the department back. We brought Tony Sanchez, who was the director of the Office of Recovery Transformation, and Dr. Terry Timberlake, director of the Office of Adult Mental Health. And they talked to us about peer supports and how that's being used and the potential that it holds for our state. So here's what we found after all of the presentations is that our behavioral health workforce crosses multiple state, local agencies, the courts, the schools, the providers, and the practitioners. That 150 of our 159 counties are considered mental health care professional shortage areas. That 77 counties don't even have a full-time psychiatrist. And only 53% of psychiatrists in Georgia accept Medicaid. State agencies, care management organizations, and other stakeholders provide multiple training opportunities. We really have a lot of training going on in Georgia across different agencies, but it's not coordinated. And so there needs to be some organization about that allows the state to move best practices forward rather than just for one agency, for multiple agencies. The Georgia Board of Healthcare Workforce, they track demographic and practice information, and we said on physicians, physicians assistants, nursing was added in 20, but data completion is required, but you're not required to complete the whole survey. So then your data is incomplete. So you can just check in, do part of it, and then not complete the survey. So the data is not complete. And then loan repayment programs are available for physicians, physician assistants, and advanced practice registered nurses and dentists who agree to work in targeted areas, but we don't have anything like that. And Chairman Tanner, we've had that conversation before. We don't have anything like that, the equivalent of that for behavioral health professionals. Something that we've always been proud of, I was proud of it when I worked at DBHDD, is we are a national leader in the certification of peer specialists. And those are individuals with lived experience who are trained to empower others. And we were the first state to include this service as a Medicaid billable service. And I cannot begin to say how important that has been for our state and the potential it holds for our state to continue to grow that and to be a leader in that. We have certified peer specialists in mental health, in addictive diseases. If you talk to the Georgia Council on Substance Abuse, they do great work on training peer specialists in addictive diseases. We have certified peer specialists for youth and for parents. And then we've got ancillary credentials for whole health and forensics. So it's much work has been done, but the potential is great. We've made data requests. The Office of the Secretary of State, Chairman, you helped us with that, and the Department of Behavioral Health and Developmental Disabilities. They have been very good to us about giving us the data we need. Dr. Serban with Georgia Tech is on our committee, and she is a die-hard researcher. So she has made some serious requests for data that the department's been very responsive to. And then the Department of Community Health. And we're in the process of analyzing some of that. And she'll follow up to my presentation to show you some of the work that they're doing at Georgia Tech on that. And I'm sure that Commissioner Fitzgerald will be interested in that also. So you'll see these are our recommendations, and we have strategic areas and areas of interest. I'm going to run through the recommendations. We have some that we think are longer term, some are shorter term. Within the next couple of weeks, we'll present. I wanted to hear the presentations of all of the subcommittees to make sure we were not being repetitive of something that was going on in another subcommittee. And we'll give you our formal written report and we'll prioritize our recommendations. But this is what we're looking at right now. This is one that we believe is extremely important. We need to do a comprehensive review of prior commission, House and Senate, and Joint Study Committee reports. We need to look at the recommendations that were made, and we need to say, did we do them? If we didn't, why? And are they still something that we need to follow up on now? Are they showing up in the work of our commission today. We think that needs to happen. It's kind of an eat your vegetables exercise. It needs to be done before we just start recreating. We need to, parity is an issue, and I was glad to see that Dr. Fitzgerald is taking that up in her committee, and we just put this in here because we thought it was important enough that it needed to show up in ours too. There needs to be parity between physical health and behavioral health. We just spoke about peer specialists. We need to look at how they're being used and develop a plan for expansion of certified peer specialists, both in all categories. And we need to look at their salaries, and we need to look at how they're funded. We need to allow psychiatric, mental health, nurse practitioners to practice to the full extent of their training and grant full prescriptive authority. They are in our facilities. They are the arms and legs of our psychiatrists. It's just not in our Medicaid plan right now. And it's something that we think is very doable, and we think it will expand our workforce. We support the idea of what Dr. Fitzgerald had in her report to propose legislation to allow licensed marriage and family therapists to conduct 1013s. They're working with the families, and we feel like that should be done. That would also expand our workforce. In training, that we need to identify the training topics and curriculum and develop tracking and training calendars across agencies. So if it's important for children in DFACS, then it's important training for children in behavioral health. And we shouldn't all have our best practice of the day. We need to line those up, because you have children with behavioral health issues in particular that flow into our detention center. And if they're using one best practice and they come out and they're in foster care and they're using a different best practice, and then they end up in a psychiatric residential treatment facility and they're using yet a different best practice, there needs to be some uniformity to that. We need to look at the salary disparities between medical and behavioral health practitioners and staff and make some recommendations about that. We need a loan forgiveness program for behavioral health professionals. We need data. And this is when we need to track data, not only on our doctors and our nurses, we need to track it on our behavioral health professionals. And we think that there are ways to do that, to just expand what we're already tracking now and make it required that people have to complete that licensed professionals must complete that information. We agree that telehealth has become a critical component of behavioral health provision in our state. It probably should have been before COVID. When you've got the kind of shortages that we have, it meets a need. And then we want to look at, we're not ready to say, we think we should do this. We think we should look at it. We should study it. The impact to workforce expansion and management of the provider network if private practitioners are allowed to bill Medicaid fee for service for services rendered. That, I think that when that was not allowed by the Department of Behavioral Health, it was because there was a thinking that if individual providers were linked to community service boards or care management entities, that when the person seeking treatment, they could get a broader array of services that way. But now we know, and we've known for a while, that we've got many areas that the only people you've got are private practitioners in counties. And so we really need to look at what would the impact be, because there would be an impact to doing it. And it's not only a workload issue, it's a Medicaid issue, it's a significant issue, but we think it warrants study. So that is the work, and that's what our committee has been doing. Dr. Serban is going to present on the research that she's doing at Georgia Tech with the data that's been provided. But I'm happy to answer any questions. I know that was a very fast run through, but I'm trying to be respectful of time.
Thank you. And again, I think everyone here can see and everyone online can see the amount of work that's went into these subcommittees over the past several months, even with everything that's been going on. I also want to take just a moment too to thank and recognize Commissioner Fitzgerald, and I know Chairman Dempsey's also here, because there's been a lot of work done over the past decade around this conversation, and Georgia is recognized as a leader in a lot of these areas, and the peer support groups is one. I hear from citizens and constituents and people as we talk around the state that's one of the most important aspects of these people's treatment they're receiving. So thank you all for all you've done to support that and to make Georgia a leader in that area. I believe Eric, who is Associate Dean of Psychiatry at the Medical College of Georgia, who's also on one of our subcommittees, is online with us, and he has a question.
Thank you. I'm trying to do two things at once. So my question is, innovative minds like Mark Johnson, who I'm happy to see on the committee now, have instituted their own residency program in order to fill their workforce needs. And as he informed me, there's at least 2 other psychiatry residency programs. And I think it's incumbent upon the state to continue to support the expansion of residency positions throughout the state of Georgia, because people who do residency in Georgia are more likely to stay in Georgia to practice, and therefore contribute to our workforce needs.
Thank you. I'll take that under advisement. I do agree with you.
All right, I believe that's all the questions. So if you want to continue.
All right, Dr. Serban, I'm going to turn it over to you.
Yeah, thank you. I'll share my screen. Let me know if you see the presentation.
Yes, we've got it.
Okay, all right. So this really responds to one of the recommendations related to data, to understanding supply, understanding where the providers are, what kind of service they provide to whom. So just a brief introduction. I'm a professor at Georgia Institute of Technology. My research is healthcare, not only focused on mental health, but my focus is primarily on system access and health systems. So I will speak to several recommendations that have been discussed today. I will focus mainly on the data issue and how that can be used to respond to some of those recommendations. This is the website, and this is where I'm planning to promote some of the data that I am acquiring right now. And we already have several data portals. One is the one reflecting and presenting the healthcare measurements and health determinants. One is related to diabetes. One is related to Medicaid disease prevalence. And I plan to have one maybe next year, mid or end of next year, related to Georgia mental health services. And just to give you an understanding that a lot of those recommendations really rely on an enormous amount of data. It's not just simply getting the some data sets, it's really compiling a lot of data sets. We need to inform where providers are with what kind of services provide to whom, what kind of insurance they accept. Those can come from electronic health records, from medical claims records. Many of those data sets are not publicly available. And so there is an extensive effort to creating those kind of data systems for the recommendations. But let me maybe focus mainly on mental behavioral health system analysis. And those were the objectives that I started with this year as part of this commission to locate the supply of mental health services. This sounds very simple, but it's not. Also to understand, to overlap that with the demand for mental health services to understand access. And most importantly, to identify communities that are most in need. And of course, children and adults are most in need for those services. And I'll discuss later in this presentation how we can use this analysis for what I call policy labs, where we can look at various policies and interventions in order to understand the impact of access. But let me talk a little bit about data sources, since this has been on our mind and in this conversation today. There are several data sources that I have in hand right now. One is publicly available, and not many actually are aware of this data source. This is a National Plan and Provider Enumeration System, which provides information about all providers in the US with their taxonomy, practice location, name, and all those that actually reimburse. And they're divided between those that are organizations, individual providers. This is an extremely rich data set. So I've been using this data set for various other projects, and I'm actually using this, and I've really streamlined this data for Georgia for mental health services. We're complementing this with the Secretary of State licensure data that I purchased recently. We have this license data for all type of licenses, mental health services. And last, I'm complementing this with Medicaid claims data. Georgia Tech, I am the principal investigator of a large research program that brought the Medicaid claims data from the Centers for Medicare and Medicaid. We have the Georgia data from 2005. The 15 and 16 data are in the mail as we speak. I just purchased this data recently. We have, in fact, the Medicaid claims data for the entire US, not only Georgia. So it allows us actually to compare Georgia to other states for benchmarking. This data is extremely rich. What this data is are the identifiable medical claims records for all Medicaid enrollees in the United States. Of course, all Medicaid enrollees in Georgia. And those Medicare records include demographics, procedure codes, services, who provided, what kind of providers, services, when, at what time, and how much they cost. So it's a very rich data set. And some of the questions that were brought up earlier could be addressed to some extent with this data if we would have access to more recent data. The most recent data I can purchase from CMS is 2016, and next year will be 2017. So we're 3 years behind. Would be great to have access to similar data, but from 2019, not 2016. We've requested data from DBHDD, which has been very supportive. We're still working on one data request, and this includes number of children treated, what kind of services provided in what schools. And right now we're working on similar data, but at the provider level. We have made a request from the CH, but from as far as I know, we have not heard back from them. This is important to actually understand the level of care provided at each provider in order to actually understand what are the capacity, what kind of service they provide, to whom, what insurance, whether the provider accepts Medicaid or what type of Medicaid programs. Those are questions that we have to answer. We need to answer in order to be able to help other subcommittees of our committee. This is how we're going to use this data. We can use this data to look at service availability at the provider level. This is the granularity we need at the provider level. We need to identify, and we have the data to right now to identify and locate where mental health providers are in Georgia. We also can use the Medicaid or DCH data and DBHDD data to understand what providers participate in state-funded programs. Furthermore, we need this additional data in order to understand, to evaluate the availability of services at each location and the modality of care, as I'll describe next. We need all these components in order to characterize the service availability at the provider level. We already know there is the mental health system is extremely complex in Georgia and not only in the entire US. We have the BHDD and the CH that provide public state funded mental health care services to various populations of children. And right now I'm talking about really looking at this for children, and we'll follow up after this for adults, but I'm taking one step at a time because looking for children is already very challenging. And then we're gonna look at adults. The workforce for mental health care is also extremely challenging to characterize, to identify, because it really comes from individual practices. Many of them actually do not accept public state-funded programs. And the individual providers, not necessarily, they could actually work for large organizations. They could work for Department of Community Health and Public Health, for example, for various programs. They can work in schools, but we also have public organizations like CSBs that are contracted by DBHDD. They primarily treat uninsurance, but also may accept commercial insurance. This is important to understand what is the capacity that is allocated for different kind of insurance type programs. And we have the private organizations, many of them, some of them are contracted with DBHDD, and then they provide community care. We have various modalities of care for children in school, in home, in clinic, telehealth. We need to understand also where and what kind of services are provided and what type of services are provided. Because every single modality of care will give us a different understanding of the access to mental health services. These are the main challenges they're facing right now with really characterizing the availability of mental health services is data. And I'm still assembling the data for addressing that question. I do have the capabilities and very really outstanding students to work on various aspects of this project at Georgia Tech. What we need is actually data, and that is reflecting, as I said, modality of care, taxonomy, type of services, all the things I've mentioned so far. What I'm showing you here on the bottom is data that we pulled from Medicaid, by clinic, for in-clinic, in-home, and school. We have right now, I've pulled only 2014, as I said, 15 and 16 is coming anytime soon, when we can see the patient home actually care is picking up over in clinic. But we can be very granular once we have access to this data. And it's also one challenge, of course, that has been mentioned are policies of reimbursement and the scope of practice and independence practices. I don't know who in the state has really done a deep dive on understanding those policies, and so we can actually really use those for characterizing workforce. And I know those are changing as well every year, and understanding the policies will also allow us understanding access. We match supply with demand for mental health services. This is, I'm going to skip this. This is not necessarily related to workforce. This is we're using a very detailed, rigorous modeling techniques that I've actually presented in my book that was published last year to match the supply with the demand. Once we have a good understanding of the supply of mental health services, we can really have a very good understanding also what is the demand that we can cover with the current supply. I don't think we have an answer to this question, and it's a quite challenging question to address, of course. We know that the providers are quite congested. We also, it's good to understand the patient travel distance, and those are a bit different, of course, by type of care. In school and in home, there is zero travel distance, but those children that only can access, or adults that only can access in clinic services, they can actually experience very long travel distances. And last, the way we can use the data and the modeling techniques that I'm proposing here and to use for addressing our recommendations is through what I call a policy lab, where we can use simulation. This is, I'm an industrial engineer, and we like to do simulations and look at interventions and policies before deployment. We can address questions on expanding loan forgiveness programs as one of our recommendations to reduce for reimbursement parity. Again, this is another recommendation. Looking at telehealth restrictions that have been waived this year with the emergency due to COVID crisis, increasing community-based care. Of course, there are lots of questions to answer. I can take questions by email as well, or I'm sure we can have a few discussions right now too. Thank you.
If you haven't met her before, I think you've realized how brilliant that she is. And if she sent me a copy of her book she published on healthcare systems. And again, if you're interested in that topic, I encourage you to read it. But we have some bright minds working here in Georgia at universities, and we're thankful that she's on our team. And I think if we can help get her the access to all the data she needs, she's going to be able to produce a great deal of results that I think will help Chairman Dempsey long-term as funding decisions are being made in the House, Commissioner Fitzgerald, because what she's doing is not telling us what we should do. It's just giving us all the data that's necessary to make informed, factual-based decisions, non-emotional, factual-based decisions. So I thank you for all you've done, and Gwen for all you've done on that subcommittee. And I think that maybe Cindy Levi had maybe a comment. So Cindy.
Yes, thank you, Chairman. My comment was just in follow-up to the comment that was made earlier regarding expanding the psychiatry residency program, and just to make certain that that the group was aware that Northeast Georgia Medical Center is going to be starting a psychiatry residency program, and it will include Northeast Georgia, and really will be a great opportunity to get training in inpatient, outpatient, and community-based services in many of the rural areas. Thank you.
Thank you. Also, I believe Dr. Johnson had a comment.
Yeah, thank you very much. I'm so glad you got access to the historic claims paid data for Medicaid. My question has to do with getting access to real-time claims paid data that we can use for a system that lets, for instance, an automatic note go to outpatient providers when one of their patients visits an ED or hospital, those kinds of real-time use. Are you aware of what the barriers are, or what it would cost to estimate to be able to have that kind of real-time data, which improves care and really does then drive integrated care?
So I did have a few attempts in the past, and I hope the commission will support this, and maybe this will be more successful in the future, to have access to the claims data directly from the CH. And I guess my request was too big at the time, because to me is getting the claims data for every single patient is important, because they all have very different profiles. And so I wasn't successful so far, but I'm hoping now with the support from the commission, we can make a request from DCH, and Georgia Tech has put in place all the safety security systems that's possible. We have the entire US Medicaid claims. CMS has provided us identifiable files. So, and that's for 6-7 years now of touch data. So we do have all the safety in place that we could safeguard the data. It's very important for me too. I understand the concerns, and I hope we will have access to DCH data to be able to make informed decisions with most recent data.
And that's one of the things that we're going to be having some conversations after this meeting and follow up over the next few weeks. Commissioner Fitzgerald and I and some others are going to be meeting, talking about specific recommendations. And as we talk about that, what are the barriers to data, because Commissioner Fitzgerald has control over the data that she's providing already, but some of the other agencies have access, and it may be a bar legislatively through the law that we need to tweak, but we'll get to the bottom of that and find out exactly what we would need to do to be able to get that full access. Because again, I think it's invaluable, the amount of information that could be provided back to the key partners. So thank you for that. All right, any other? Ms. Skinner, you have any follow-up?
No, only I would say that Dr. Serban, I think the capacity to be able to do simulations where you say, if I change this policy, this would be the impact to Georgia, is a great opportunity for us to use Georgia Tech in that way. So no, thank you, Dr. Serban. I appreciate it, and I appreciate all of the work you've put into this, and my other committee members. I've been blessed. I have a very good committee. They're very responsive.
Thank you very much. Yes, I think that one of our priorities has to be making sure that we get her the data that she needs, because I know Justice Boggs is with us. And one of the things I hear him talk a lot about is they did this with criminal justice reform, but making fact-based, statistic backed up decisions. And that's exactly what she's talking about. And to be able to, for a subcommittee to be able to say, this is what we think would be beneficial, but for her to be able to plug that in and give us some real factual feedback on that policy change could be very important. So thank you for that. And we'll make sure that we do everything we can to get her the information. So thank you.
Thank you.
All right. We're getting ready to move forward with the next presentation, but lunch is here. So let's take just a brief 5-minute restroom break and time for the members of the commission to get their lunch. We'll have a working lunch. We're a little behind schedule, but as you can tell, we've got a lot of information that's being put out. So we'll take a brief break and then we'll come right back. All right, again, we'll go ahead and get started. We've got, still got quite a few reports and good information to go through. And again, we're going to have a working lunch, so feel free to continue to enjoy your lunch. And lunch is on me today, so that's a Kevin Tanner lunch. That's all I can afford. But enjoy that. You're welcome. I appreciate all your hard work. Like I said before, we've operated under some difficult times, but as you can tell, our subcommittees have been very busy, and you're going to continue to see that. Judge Amaro, if you are with us and ready, you're up next. Judge Amaro has been very active chairing the subcommittee on involuntary commitment. And let me just say, all of our subcommittee chairs have been active for years, and Judge Amaro has been an advocate for mental health in the criminal justice field for years. Superior Court judge down in Henry County, and just have really enjoyed working with him. He's extremely passionate about this topic and is leading in this area across the state and really across the country. So thank you, Judge Amaro, for all you've been doing.
Well, thank you, Chairman Tanner, and thank you for this opportunity to speak to the group. As you have indicated, I'm the chair of the Involuntary Commitment Subcommittee, but I'm also a member of the Mental Health Courts and Corrections Committee that is chaired by Justice Boggs. And there is significant overlap between our groups, and I think that'll become apparent as I move along in my presentation. And I really wanted to give you, by way of opening, a street level view of what behavioral health issues we're seeing in the court system. And when I think about examples to share, I have a couple of short stories that illustrate why I've become involved in this work, why I'm so passionate about the need for us to engage in innovation and reform in this area. The first story arises from a case involving a 35-year-old Hispanic woman who I met over at the local jail recently. She was in a forensic cell without windows, lying on a metallic surface, which we'll call a bed, draped in a paper robe of sorts, unresponsive. I asked the staff there about her, and they said she doesn't take her medication, she doesn't respond to her name, she's pregnant. And I said, well, how long has she been here? And they said, well, a couple of months. She's waiting on a hearing in a probation revocation matter. And I said, well, has anyone tried to 1013 her? And we got the sheriff on the phone. The sheriff came down to the cell down in the basement of the jail and said, yes, of course we've tried to 1013 her, but nobody will take her. So this is where she sits. This is where she lays 24 hours a day in the dark basement of the jail in this condition. That's example number one. Example number two is a case I've had recently right here in this courtroom, where I had a 52-year-old man who suffered from schizophrenia, who sees snakes all the time. He also has co-occurring problems. He drinks when he shouldn't, and he uses meth when he shouldn't. And when he is in the throes of, when he's drinking or using meth, and he's also experiencing the symptoms of this schizophrenia, he sees snakes that are biting at his ankles, biting at his legs. His mother, his 81-year-old mother who he lives with, has to tell him, they're not real. Don't worry, calm down. Sometimes he thinks that there are people coming through the walls, attacking both him and his mother. And his mother has to say, his 81-year-old mother who's frail, has to tell him to calm down. It's not real, no one's coming through the walls. but that's not the world as he sees it. And at times he gets agitated. And in one occasion, he decides that they're coming at him in such a way that he has to fight back. And what does he do? He uses his fists. He smashes his fists into the drywall, creates damage throughout the house, yelling, anger. His mother becomes frightened. His mother does what? Calls the police. The police come. They arrest him for criminal damage to property in the second degree. And now he sits in the local jail, languishing, while his attorneys and the state try to figure out what to do with him. I bring these two examples to your attention because every time I see this, and I see it multiple times a month over a long number of years, I ask myself, why is it that I am having these issues to deal with here in the criminal justice system? Why is it that this public health system, a state agency that we spend $1 billion a year in connection with, is not somehow managing these issues before they get to this point? How is it that we can do better? How can we shift some of the people who are in this condition back into the public health arena? Where can we make better interventions to prevent this type of problem from occurring? And if it was just a couple of times a year, I would understand that no system is perfect. But myself and my Superior Court judge colleagues all over the state see this routinely, month after month, year after year. So this informs my work. This informed the beginning of my involvement with this involuntary commitment subcommittee. And we met twice. We met on February the 7th of 2020. And we heard from Judge Sarah Harris, a member of our subcommittee, who was also a probate court judge in Bibb County. Harris gave us an overview of the legal framework for involuntary commitments in Georgia. Then we heard from Dr. Emil Rigsby and Dr. Del Mendoza, both from the department, who gave us an overview and understanding of how it is that people like this are managed once they are sent to them for their care and for their treatment. They told us about the lack of availability of beds, the lack of resources in the community, gave us some insights into better ways that perhaps we could manage this population. Then we heard from Dr. Karen Bailey, who's also a member of our subcommittee. She is the director of the Office of Forensic Services for the Department of Behavioral Health and Developmental Disabilities. And she gave us an inside view into what the department does when I enter an order. Judges like myself enter an order requiring that they look into the competency of people like those I've described to stand trial, and also gave us some insight into the restoration services they provide, both inpatient and outpatient. Also, Dr. Bailey spoke to us about the criminal responsibility evaluations that they do when people come into her care with this type of issue. She also gave us some insight into the work that the department does when we find someone not guilty by reason of insanity, and how they manage their care on an inpatient, outpatient basis. So we evaluated those resources and the current systems that are in place to manage this population. Our next presenter was Brian Stetton, and Brian is from the Treatment Advocacy Center, and he spoke to us in a way that allowed us to see a couple of reforms that would be appropriate to better managing these folks on the public health side. And he's going to talk to you at length about assisted outpatient treatment as a viable approach to stem the flow of people with severe and persistent mental illness into the criminal justice system. He's also going to suggest a couple of statutory tweaks that will allow us to intervene a little bit sooner to prevent people from devolving to the point where they are arrested. He'll be our featured speaker today, and I'm really looking forward to seeing him and hearing from him again. He's fantastic. At our next meeting, we heard on July the 9th of 2020 from Judge Stephen Leifman from the 11th Judicial Circuit in the Miami-Dade County, Florida. And Judge Steve Leifman is really a superstar in the area of systems innovation. Dr. Leifman took a look at the involuntary commitment laws in Florida, took a look at the involvement of people with severe and persistent mental illness in the criminal justice system, and came up with a unique approach to try to keep them, to immediately connect them to treatment, whether they come in through the civil side or the criminal side. He recognized that the thing that involuntary commitments and mental health and the criminal justice system have in common when dealing with people with severe and persistent mental illness is that the people are the same. And we have an irrational set of policies and systems at the intersection between criminal justice and public health that he's helped to make more rational, that he has, and I tell you, the results that he has been able to work in those systems in Miami-Dade County are just remarkable. The statistics are incredible. But I just want to very briefly introduce you to him. He's the star of a PBS documentary, The Definite. And I'm just going to give you the trailer just to give you a sense of the type of problems that we're seeing in the courts, that we're seeing with people with severe and persistent mental illness. And if I could just call in my technical expert, James, to assist me with the presentation of this short video.
11 years ago, I was in jail on the 9th floor in the Dade County Jail. I'm laying in a pile of feces, vomit, and urine. I'm sick, I'm hearing voices, I'm seeing things, and they're like, oh, we'll put you on the psych floor. Thank goodness. Some people that understand me. If I get up there, it's way worse, man.
Last year, about 1.5 million people with serious mental illnesses were arrested.
Our jails have become the largest public psychiatric institutions in the country.
We were spending $80 million a year to warehouse people in conditions that you wouldn't let your dog stay in.
Water's not working. He's drinking sewer water. He's drinking toilet water out of the toilet.
We know how to fix it. It's a question of political will and leadership. It's foolhardy what we do now, and it's cool because we're not affording people the opportunity for recovery. We have this amazing program with amazing people that could help keep you out of here. And I'd like to do that.
I always had a normal life. After I had this whole schizophrenia thing, I didn't know what was going on. It's real psychological warfare.
He was looking at 5 years minimum. They just needed to diagnose him. And this kid has a total different life. Oh man, my ankle feels a little lighter.
I'm in recovery. Drugs, alcohol, mental health. You know, I've said stuff to people, and they'll go before the judge. Man, this boy crazier than me. Why am I listening to him?
Let me see the medication.
No, I don't want to go.
We're here to help you out.
What's he facing?
I have approximately 45 years state prison.
See how you look picture perfect, and then all of a sudden within a minute, everything had just collapsed.
Give him a seat. Give him a seat.
I have mental illness that's going on within me, so I try my best every day. That's all I can do.
We're increasing the quality of life for our community and for our clients. There's no doubt.
You proud of yourself? We're proud of you.
They're just people, and they want to do everything that everybody else wants to do. They want to be happy. They want to have dreams. So now we have a totally different system.
All right, well, that's Stephen Leifman. That's our judge. I hope everyone was able to see that. Do we have a problem here?
When JMC was started, Charlie Gonzalez was not as eligible. Only Mr. Meek.
All right, sorry about that technical issue, that little glitch, but if you remember from just a moment ago, Stephen Leifman, I call him doctor because in my opinion, he is a doctor, he's a judge, he's a lawyer, he is the be all end all, he's my hero. I'm hopeful that at some point here in Georgia, that we can listen to the advice and guidance of Judge Stephen Leifman, that we can have the type of systems in place that treat people with severe and persistent mental illness humanely, avoiding the criminal justice system whenever possible. And I just want to give you a couple of statistics from his 2020 report. He said that of roughly 55,000 bookings into the jail last year, approximately 11,000 involved people with mental illnesses requiring intensive psychiatric treatment while incarcerated. On any given day, the jail houses approximately 2,400 individuals receiving psychotherapeutic medications and cost taxpayers roughly $232 million annually, or $636,000 per day. Dr. Leifman, Judge Leifman, has made it crystal clear that we are treating people in the least appropriate setting, the county jails, when they should be treated in the public health system. Next, we heard from Dr. Ken Minkoff, who proposed to the group an ideal system of care, which suggested a much more rational way of helping people who are in this circumstance. His ideal system of care would allow every individual and or family in Georgia access to a continuum of best practices in behavioral health crisis services that are welcoming, person-centered, recovery-oriented, and continuous. And I have all of the presentations by all of these esteemed presenters available for the commission at any time to review. At this time, I'd like to turn it over to Brian Stitton, who's our featured presenter. I believe that assisted outpatient treatment on the involuntary commitment side of things is a real potential solution. I know that Nora Haynes and Representative Don Hogan have put a lot of time and thought into this sort of solution for people with severe and persistent mental illness. And Brian, if you would please go ahead and share your presentation and your recommendations. Thank you.
Certainly. Thank you so much, Judge Amaro and Chairman Tanner and all members of the commission. I'm very grateful for this opportunity to present to you today. Of course, I very much appreciate Judge Amaro's remarks, which I think really set the stage beautifully for the information I would like to present on my organization's recommendation for how Georgia can improve its civil commitment laws and practices. Just to tell you a little bit briefly about the Treatment Advocacy Center, the organization for which I'm very honored to be the policy director. We are based in Northern Virginia. We're a national advocacy group that works around the country to remove legal barriers to the treatment of severe mental illness. We sort of see ourselves as a voice of people very much like Judge Amaro is describing in those heartbreaking vignettes, people who by no fault of their own are unable to recognize their own desperate need for treatment for their severe mental illness, usually due to lack of insight. And of course, their families who suffer horribly right along with their loved ones. And as you might expect, we are keenly interested, especially in the civil commitment laws of every state, which are at the end of the day, the key to finding better answers than we have so far for the folks that Judge Romero described. And so we delve very deeply into the civil commitment laws of every state as we have into Georgia's. And I would like to present to you, if I may share my screen, my recommendations for how we think Georgia's laws might be improved to learn some lessons that we've observed in other states. Let me just go into screen sharing mode here. Just one moment, sorry. I'm not quite as smooth at this as I ought to be at this point. Okay, I'm now sharing my screen. Hopefully you can see that. Let me start my slideshow. Okay, so you're all seeing my slides now, I hope. So just to give you a basic overview of what I'll be presenting today, our recommendations are for both improving outpatient commitment and inpatient commitment in Georgia. Our feeling is that on the outpatient side, the law as it stands now is actually excellent. We really have no quibbles or recommendations to improve the law on outpatient commitment in Georgia. We do think that there are many miles to travel to improve the practice of outpatient commitment through the implementation of what we call an assisted outpatient treatment, or AOT model. And I'll make a recommendation after describing what AOT is on how I think Georgia can get further down that road. On the inpatient commitment side, we do see some opportunities to make some changes in the law that we think would make it a whole lot easier to get people help before they wind up in the clutches of the criminal justice system or victimizing someone or victimize themselves, as so many tragically do. So let's start with a discussion then of outpatient commitment. And our recommendation here is to establish a statewide grant program at the department, at the BHDD, to promote the practice of assisted outpatient treatment, or AOT, which I will now describe what we mean by that. And before I get into exactly what AOT is, why I feel Georgia needs it so desperately, I should make clear that I never want to suggest that AOT is a magic bullet for everything that challenges public mental health. It is not. It is a tool in the toolkit. It's basically a Phillips head screwdriver in the drawer for addressing a particular challenge that's universal to public mental health. But it's not going to make all the other problems go away. On this slide, I've kind of ticked off what are some of the major issues that we hear around the country that public mental health systems are dealing with. I'm sure if you take a look at these, they're all going to be familiar to Georgians. And I know with the expertise we have in this meeting, we could fill many, many more slides with other equally compelling challenges. But there's one I think maybe gets short shrift in the attention that's paid so much to the fact that there are inadequate resources to address so many particular needs. And that is the problem of treatment non-engagement, right? The fact that there are some individuals in the public mental health system, by no fault of their own, who have great difficulty engaging in the care that is made available to them. So that if in a particular person's case, you are able to solve all those other common problems, so you're able to offer somebody that package of outpatient services they need and the medications they need, and there's a way to pay for it, and all the caregivers they have are available to them, there are still many people in that situation who will pull away from treatment, who will disengage because of their inability to understand their own need for it. And while if we can address that particular problem, I will never suggest to you that it's going to make all these other issues go away. But I would say that what we are doing by doing such a poor job in dealing with treatment non-engagement is we've created a class of super utilizers, people who are coming into the system again and again, who are consuming a disproportionate share of the scarce resources that are available, such that it makes all these other problems that much worse. Because we're allocating resources so inefficiently. And we're talking here about folks who we say are caught in the revolving doors of the mental health and criminal justice systems, people who rack up staggering numbers of hospitalizations, get arrested again and again, largely because of the difficulty they have engaging with treatment on a purely voluntary basis. So what is that about? Why is it that people with this particular type of illness, unlike so many others, often refuse care, don't on the surface want care for the needs they so clearly have? I wouldn't want to give you a simplistic answer to that. There are many reasons. Again, I've ticked off some of the major ones, what you might see in different combinations in any particular person's case as to why somebody might disengage from the treatment that's made available to them. Again, I'm sure we could fill many more slides with other reasons, but yet again, I've highlighted one in yellow that I think has not been understood enough in policy discussions, and that is the problem of lack of insight, or as it's clinically known, anosognosia. And this is a symptom of brain dysfunction. This is about the brain not working in the way it is supposed to for folks who have severe mental illness. And this is not in a person's control. And what we're talking about basically is a lack of insight, an inability to recognize, no matter how painfully obvious it is to everyone around the person, the need for treatment and the existence of an illness. This is sometimes mistaken for denial. You know, someone will say, my son is in denial, he doesn't want to take meds. I think it's important for us as policymakers to recognize the difference, right? Denial is a universal human defense mechanism. It is something we have all practiced from time to time when there is some painful reality we don't want to admit to ourselves. But when we're in denial, we really do know the truth. We just need some help, maybe coaxing that to the surface so that we can confront it, move on in life. That's not what's going on with someone with anosognosia. This is brain-based. This is about dysfunction of an organ of the body. It is out of the individual's control, and they don't know the truth deep down when they're experiencing anosognosia. And for some people, this is a fixed issue. For others, it's something that waxes and wanes. And there are many people with severe mental illness who don't suffer in addition from anosognosia, who do recognize their illness. It's not universal. But for those who are there, who are having this issue, we have to resist the temptation to be frustrated with the person, because when you put yourself in their shoes, their non-adherence to treatment is perfectly logical, rational, and sensible. You know, the medications that we want folks to take, let's face it, they've come a long way, but they're still not to the point where they don't have unpleasant side effects. There are still many hassles involved in being beholden to a treatment regimen. And when you are only seeing those negatives and don't see what this treatment has to offer you, you don't understand you have the problem the medication is designed to solve, of course you're going to want to have nothing to do with that treatment. And so that's what's going on with folks who are experiencing anosognosia. Here, just quickly, is some brain scans that show this as a physical phenomenon. You're looking at brains of two individuals with schizophrenia, one with anosognosia, one without, at a moment where they're being asked to perform a self-reflective activity. You can see brain activity, right? Synapses firing in the brain of the person with insight that just aren't happening for the other person. And, you know, obviously this is no more reason to be frustrated with somebody than would be dysfunction of any other organ of their body. So admitting then that anosognosia is one of many reasons on a list of why people often have trouble engaging with treatment. Why is it I would suggest it's the one we really want to pay attention to as policymakers? There is a fascinating study published in the journal Psychiatric Services that looked at 300 patients who had been identified as having trouble adhering to treatment for their severe mental illness. They started with baseline interviews, and they actually found that most of the folks in this sample had other reasons, right? 2/3 of this sample did acknowledge and understand they had an illness. It was only 1/3 that insisted they did not. But when this sample of 300 folks was tracked over time, there were extraordinary correlations found between that 1/3 of the sample who were unaware of their own illness and how much these folks were suffering as a result of their non-adherence. So the individuals with anosognosia were much more likely to completely cease taking their meds as opposed to missing doses or tapering off, much more likely to have severe symptoms in the community, much more likely to be hospitalized. On metric after metric, this was clearly the ball we want to keep our eye on if we want to do something meaningful about this problem of treatment non-adherence. And this kind of brings me to my bottom line on anosognosia. And here I like to invoke that corny movie, no pun intended, Field of Dreams. And if you've seen it, you remember that iconic line, if you build it, they will come. And there are many folks who tell us that very thing about the public mental health system, that the problem is simply about not doing a good enough job of getting resources out into the community. And if we build that great system of community-based care, people will come flocking into it. And look, I'm not comfortable putting myself in direct opposition to that point of view, because I actually do think there are many people who would be helped if we simply did that. But I think we have to recognize, for those who suffer from anosognosia, Building that system is a necessary but not sufficient part of the puzzle, because we have to do something more. Common sense tells us that people who don't believe they have the illness that system is designed to address are going to come flocking into it simply because it's been built. If you don't see its relevance to you, you're going to stay in those weeds. And so that's where this mechanism that I'm about to describe of assisted outpatient treatment comes into play. It's about that extra piece we need to ensure that people who lack insight into their illness engage with treatment for a period of time such that they can come to understand its importance in their life. So AOT then is a clinical legal strategy. It's about a collaboration between the mental health system and the court system to help overcome an individual's natural inclination to disengage from treatment. This is a form of civil commitment. We're all familiar with the civil commitment to inpatient care, where a person is currently in a psychiatric crisis, doesn't understand their need to go to a hospital, and so we make a decision as a compassionate society to send them there. Here we are talking about individuals who may not be at that stage, who are at a moment where they're not in acute crisis, they don't need to be in a hospital, but they have a history, an alarming history of winding up there because of their demonstrated inability to adhere to treatment voluntarily. And so we are civilly committing them to stay engaged with a plan of outpatient treatment. And this is a mutual commitment. This is also just as much about putting the system on the hook to deliver those services, as I'll get into. So just a point of clarification here. One thing that became apparent at the subcommittee meeting that Judge Amaro held in February that I was very happy to attend, we heard from folks from many Georgia counties who actually talk about the fact that outpatient commitment, as it's authorized under Georgia law, is already practiced. It's fairly routine in many Georgia counties for people coming out of hospitals to be placed on outpatient commitments. And so this might lead you to wonder, well, what is it I'm suggesting needs to be added to that equation? What's missing from the current practice of outpatient commitment across Georgia is this comprehensive approach that we call assisted outpatient treatment, or AOT. This is about treating that court order much more seriously than it is taken now by the system. It's about developing a problem-solving court, very much what you saw Judge Leifman is operating on the criminal side in Miami, where the court is taking an active interest in this person's recovery. We're focusing this not just on everybody coming out of the hospital on an inpatient commitment, but we're trying to identify specifically the folks who are trapped in that revolving door. And we're going to give them much more intensive monitoring than people under outpatient commitments in Georgia get now. And of course, that court oversight of both sides' adherence, each side's upholding its commitment to the other, is key to this, as is that there be a systematic response when it becomes apparent that the person is not adhering to treatment, that we use the tool that the law allows to give that commitment some actual meaning. These are all the things that make up what we call the AOT model that we would like to see Georgia adopt. So let's just talk a little bit briefly about what this court order is about, because I think it's important to understand how it's different than what those of us who are lawyers think of as court orders generally. Normally, the reason a court order has meaning is that we don't want to be held in contempt of court for violating what the court has directed us to do. With AOT, we take that option off the table. An AOT judge is never going to hold somebody in contempt. We are not trying to find a creative new way to put somebody in a jail cell because of their difficulty engaging with their treatment. Nor are we going to automatically return somebody to an inpatient commitment as some sort of punishment for violating their outpatient commitment. You still have a constitutional right to be in the community unless and until you meet those inpatient commitment criteria. And nor are we going to forcibly administer meds to somebody who hasn't taken them as a judge has directed. That kind of restraining of a person and forcibly administering meds is something that happens as a last resort. It's an unfortunate circumstance that becomes necessary at times in a hospital setting when there's an emergency or when a person is found to lack capacity to make treatment decisions. That's not what we are going to use to make this court order meaningful when someone's in the community. Which raises, I think, a reasonable question. Well, what is the point? Is this something of a paper tiger? And I can see why it would seem that way on the surface. But what we know from experience is that there are two very real reasons why the court order does, in fact, matter and make a difference in people's lives. One is what we call the black robe effect. And it's simply the idea that it gets a person's attention to be directed to do something by a judge and to go through the ritual of a court hearing and have a judge decide this is something that you need. It's just fundamentally different for someone who's been inculcated to think of a judge as an authority figure, as we all have, than being told by your doctor or your mom for the umpteenth time that, hey, you really ought to take these meds. And our really great AOT judges around the country really embrace this role, that they understand they have a part to play in motivating participation in treatment. And they try and form that bond with the individual that they carry through over time. And as we've already said a little bit, this black robe effect, of course, works on the treatment system too. It's not going to be the nature of someone who's been told by a judge to make sure this treatment plan gets delivered to not take that seriously when they know they're going to have to come back before that judge and report on that patient's progress. And the other thing we're accomplishing through this court order is we are facilitating a rapid response to non-compliance with treatment. And although we've said that there is not going to be any punishment attached to this court order, it's not to say nothing is going to happen if the person does not follow through. There must be a legal response. And what the law provides for is an opportunity to bring the person back to the hospital for a short-term hold to determine whether it's necessary to modify the order and not bump the person up to a more restrictive level of care. Now, in many cases, you're not going to make that finding, and it's going to be appropriate to let that person go back to the community. But we want to couple that pickup with a reappearance before the judge for the judge to say, hey, we have to let you go today, but we all know where this is headed because let's look at your history. It's what happened to you 9 times in the last 2 years. And you don't like going to the hospital and we don't want to see you go there. So let's all work together. That little bit of opportunity to respond to non-adherence to treatment sooner than you might otherwise be able to is really all the teeth we need to make this law meaningful and effective.
All right.
Yep. Am I running low on time, Judge Romero? I want to make sure I don't.
Oh, please go ahead.
Okay. Do I have about 15 minutes or so?
Unless Chairman Tanner says otherwise, I think that's fine.
Okay.
Yes, go ahead.
Thank you so much. So this court order is not only for people who are currently saying that they don't want to adhere to their treatment. The legal criteria allow us to choose the patients based on their history and fragility of their condition, not whether they are currently in a crisis. So you are most often going to use this once it's in place for people who are coming off of a hospital commitment or out of a hospital stay, who at that moment hopefully have been stabilized to where they do recognize their need for treatment. Most people are going to enter this program happily and willingly. They're going to view it as a ticket out of the hospital. And so you might wonder naturally, well, what's the point of putting somebody under a court order to do what they have said they actually want to do? The reason for that is that we understand the typical pattern of people who are in this predicament, right? Many often do leave the hospital with every intention of staying engaged with treatment, but have a difficult time holding on to that intention. So that 2 weeks later, a sort of euphoria sets in when things are going great. They often start telling themselves, hey, maybe I don't really need these meds. We want to get in front of those thought processes. We want this court order to be in place and a person to know they're going to have to come back before the judge for a status check, for a progress report, before those undermining thoughts start to creep in. So it's not generally necessary, however, to do this as to have a full adversarial hearing because the person is acknowledging that they meet the criteria in most cases. Of course, if they do want to challenge it, they absolutely have that right, and we have to have a process in place for that to happen where the petitioner has to meet their evidentiary burden. But in most cases, once this program is up and running, you will find that you do a whole lot of stipulations, right? People acknowledge, they meet with their counsel, they acknowledge they meet the criteria, and the judge can enter a stipulated order. But it is still very important that all that goes before the court and the person has that opportunity to come before the judge. We don't want to do, private side settlements that don't involve the court, because that would be depriving the individual of that secret sauce of AOT, which is that opportunity to engage with the judge and have the sense that the judge is not only monitoring my treatment, but also is my champion, is on my side, is going to make sure I'm getting the care I need, right? And our really great AOT judges really seek to push those messages to the individual when they meet them, congratulate them for a great decision to join this program, and let them know that they care about what their life goals are, what they want out of this program, so that every subsequent hearing is about, hey, what progress have we made towards helping you meet your life goals, get to where you want to be. And how do you feel about the treatment you're getting? Do you feel like the system is upholding its end of the bargain to you? A person sensed the judge as their champion. It just totally changes the paradigm of how people feel about coming to court. Many of these folks have had very bad experiences with courts in their life. This is a game changer. And the greatest misunderstanding about AOT is that this is about arm twisting or coercion. The program would never work that way. It's effective because people come to feel the love of the treatment team in the court. Just quickly would like to show some of the research we have just to bring this into the realm of the real world as to whether or not this actually works. We have lots of data from my home state of New York, where I was, as an assistant attorney general, was involved in enacting and drafting Kendra's law, the AOT law that has been the model for many states since, that we passed in 1999. We have really phenomenal data on how effective it has been in reducing people's likelihood of going to the hospital, cutting likelihood of hospital admission and number of days spent by enormous rates, cutting likelihood of arrest in half, reducing the likelihood of violence. In the interest of time, I'm going to kind of speed through some of this data, but if anyone wants to nerd out with me at any point later, I'd be more than happy to do that. We have data from New York that suggests it's not just about the treatment itself, that the court order adds value. There's no question people tend to get a better package of services under AOT than they had before. But even when you compare people who are just getting those services to those who are getting those services plus a court order, you find added value in the court order itself. Respectful treatment is the key to making this work. The research found that people who were under AOT programs, contrary to some of the predictions made by skeptics, were not more likely to feel coerced or stigmatized by being part of the public mental health system than other folks in the public mental health system. What tended to predict whether folks had those feelings, whether they were in AOT or not, was how respectfully they felt they were treated, how much their dignity was recognized, how much they were engaged in discussions and collaborations over what their treatment will be. That was the key to people not feeling coerced or stigmatized, whether they were under a court order or not. And I hope it's clear that there's nothing about this model that should ever interfere with treating people with respect. And of course, this is the data that gets people's attention, even if they're not as concerned as we all are with the plight of people with severe mental illness. This is a no-brainer from a purely fiscal point of view. The modest investments that must be made to build these programs are dwarfed by the savings in reduced hospitalization. And so much of the controversy that once swirled around this concept, I'm happy to say, has faded. This is now recognized by SAMHSA as an evidence-based program and practice. It has been incorporated into the sequential intercept model, which SAMHSA promotes to promote diversion from the criminal justice system. AOT, as you can see here, has been made part of that sequential intercept model at intercept 0 and 5, preventing people from getting into the criminal justice system at all. And also it has some utility in helping people as they're discharged from jail when that avoidance hasn't been accomplished. And this has led to the creation of this SAMHSA grant program, which we're so thrilled as an organization to have been involved in starting and working with the grantees as a technical assistance provider. I'm sorry that Georgia has not been part of receiving some of these grants that have been issued, 36 since 2016. We have many programs up and running now across the country, just building this evidence base we have as to how effective this approach is. But in the absence of Georgia receiving SAMHSA money, this brings me to my proposal that I make to you today on what Georgia can do to promote as a state the implementation of AOT. To replicate what SAMHSA has done on the state level, I think would be tremendous. To make a grant fund available through DBHDD for counties to receive multi-year funding to implement this AOT model, and to award those grants competitively based on applications that come in from county mental health systems, in which they can establish and demonstrate both their understanding of this AOT model and their readiness to implement it. The fact that they have all the pieces in place with just a little bit of support to devote court resources and maybe some modest increases in the treatment services that are available to get up and running with AOT. We could do this on a pretty small scale initially, just to create a beachhead, right? Establish through model programs the success of this concept to attract attention around the state and create a basis for us to build this to a statewide level in the years to come. So that's our recommendation on AOT. In the few minutes I have left, I'd love to walk through some of the recommendations we have on how to improve inpatient commitment in Georgia. Inpatient commitment is the other hand we have to wash here, right? If we're going to do something meaningful about the tragic folks that Judge Amaro described. There is also a need for people to get stabilized when they are in a psychiatric crisis before we can get them to a point where AOT is likely to be effective. And we see three major flaws in the inpatient commitment law, really quick and easy legislative changes that could be made to make it easier to get people the hospital care they need to avoid lapsing deep into the crisis that it's so hard to extract them from. The first change on that front would be to remove the requirement of imminence in that inpatient commitment standard that we have now, right? So if you look at the current law, it requires that you show not just that the person is in need of involuntary inpatient treatment, but they are currently on a road to suffering harm or causing harm to someone else where that harm is imminent. And you have to find the person is either at risk of imminent harm themselves or is so unable to take care of themselves as to create an imminently life-endangering crisis. You know, the heartbreaking aspect of this is that it means that we have to wait around when it's obvious to everyone involved that somebody is inextricably down that road. We have to time our intervention such that we get to them just before something horrible happens. And of course, it's not always easy to time our intervention so perfectly. Oftentimes, because we're waiting around, waiting for that to happen, the tragedy does strike. That terrible thing that we're trying to avoid actually has to occur. And that's how the person proves they are dangerous to themselves or others. Now they're often in the clutches of the criminal justice system or have victimized themselves in some horrible way. Of course, the other tragic aspect of this is that we are delaying urgently needed treatment when we really don't have the luxury of delaying treatment. We know from so many studies that the sooner you can get care to somebody who is under an untreated state of psychosis, the greater their prospect for recovery. And we are lowering somebody's ceiling by allowing them to remain in an unmedicated state for so long. One quick change we can make, just pull those words right out of the law so that you can react to a crisis that we all have reason to think is coming even before it's imminent. Second recommendation would be to add to the basis on which you can respond legally, add to that the opportunity to address psychiatric deterioration. Right now, the law in Georgia does acknowledge that a person can be dangerous to themselves in various ways. We don't have to wait for someone to be violent. We can address a person's danger to themselves if they are putting their physical safety at risk by walking into traffic or not eating, or living on the street in some dangerous way, or maybe taking some intentional act to harm themselves. But what we haven't recognized is that the harm to the brain that occurs when somebody is in an untreated state is itself a form of harm to self. There is that risk of irreversible harm that grows each day that we allow somebody to psychiatrically deteriorate. And even if someone has their basic physical needs met because they have a loved one who's taking care of them, that living hell they are experiencing each day, and again, pushing recovery further out of reach, ought to be something that we can respond to as a compassionate mental health system. And in fact, 20 states have incorporated such language into their law. It would be very easy to do in Georgia by simply adding a new grounds for commitment where you could respond to the fact that the person lacks sufficient insight to make their own responsible decisions with respect to their treatment. Then we don't have to wait for them to show that they are physically harming themselves. We're recognizing that harm to the brain as equally meaningful. Final recommendation I would make legislatively would be to increase the period of emergency mental health treatment. When someone comes in for a short-term hold to evaluate them, they are currently required to be released within 48 hours. Adding 1 day will save many lives. We know from many states that have a 72-hour hold period that it is a difference maker. A lot has to happen during that emergency hold period. You've got to stabilize a person, you've got to evaluate them, and hopefully connect them to an appropriate level of care if you're releasing them back into the community. And that 48 hours just puts enormous pressure on the system, frequently leads to a premature release of folks. And we just have so much research that shows that stabilizing a person and carefully planning their post-release care will reduce the risk of post-discharge suicide. And so by simply expanding that hold period to 72 hours, we can make, we think, a great difference. So those are my recommendations. I remain at your call and happy to answer any questions if there's time left. I greatly apologize if I went too long, but I am appreciating the chance to share information with you.
Well, thank you, Brian. Thank you so much for your presentation. We're grateful for your expertise and your dedication to these issues. I also, by way of closing, want to thank again Nora Haynes and Representative Don Hogan for their insistence on us pushing forward a solution that involves AOT. I also want to thank all of our subcommittee members for their engagement in the deep thinking and innovation associated with this set of problems. So I'll stop there, and because I know that we're getting short on time, and I want to thank the chair for the chair's indulgence.
Judge, thank you very much. A great presentation. I know there was some legislation, Brian and Judge Amaro, that was introduced around AOC, and I think you've had an opportunity to review that. Is that a model piece of legislation that you would recommend? Are there changes that you've noticed that we needed to make to that? Do you have a model piece of legislation for AOC?
Yeah, Chairman Jenner, you know, having reviewed the AOT laws of every state, I really can't find fault with the law that you have now, to be perfectly honest with you. You know, I commend the intent behind the bill to make AOT finally happen in Georgia. In a way it hasn't, despite the fact that it is legally authorized. My own feeling is that the way to do that would be, you know, as I suggested, through making some money available on the state level to promote it to local mental health systems. I don't really see much room for improvement in the law. I think the tools are already there. You've got a sufficient period that a person can be under the order. The criteria for what it takes to get somebody under AOT are adequate. The response to non-adherence is right there in the law already. I just can't find any flaw in the current law. I just don't think legislatively that is the direction to respond to the frustrating reality of non-use of AOT.
All right, thank you. All right, Chief Deckmar.
Yes, thank you. Judge, good afternoon.
Good afternoon.
Did your committee have an opportunity to look at enabling legislation for law enforcement? Presently, as the statute reads, the individual first has to commit a crime before we can take them into custody for evaluation if we believe they're affected by mental illness. Unlike other states, and the one that I frequently refer to is Florida with the Baker Act, that allows them to take them into custody for the purpose of a mental evaluation if they have probable cause to believe that they're affected by mental illness. And you may have gotten a copy of one of a case study that we had in our agency, where in 2 years we had 70 encounters with an individual that resulted in 12 arrests. And as frustrating as the courts get for seeing a couple of these cases or several of these cases or a dozen of these cases a month, the police are dealing with these cases every day. And it's only after there's a crime that frequently they get to the court where treatment's available. So I would be interested if your committee looked at that.
We have not yet. That's something that hopefully we can tackle going forward. I'm a supporter of the Baker Act. But this is not something that we have dug too deeply into as a group with the limited time that we've had. I'll also say to you that I think that there are some solutions that we could take a look at from the time of the 911 call, where we could connect people with severe persistent mental illness, these types of calls that to GCAL. I mean, is there any reason why we can't do a handoff from 911 to GCAL right there in the moment, and maybe do a co-occurring, I should say, a co-responder type of model across the state that helps police by sending some mental health professionals into the fray to assist. I think that we can de-escalate much better if we do something like that. And we can supplement the training that the police officers have received. And I suspect that we would find much better outcomes.
You know, I know all the committee members know this, but for folks who may be watching this electronically today, you know, the depth of experience that's on this commission is really unmatched, I think. Chief Dekmar, for instance, former president of the International Chiefs Association, which is every chief of police in the entire world, during his year as president was his focus was on mental health issues. So to be able to have the type of depth of knowledge we have that from the folks we've heard from, look forward to Chief Dekmar being able to work with Judge Amero to find real solutions to those police encounters as we continue to move forward. Judge Weaver, I believe you had a question.
I did, Brian. Hi, this is Brenda Weaver. A couple of weeks ago, I had Shannon do a survey of the individuals who are waiting in our local jails across the state to be picked up, and had some discussions with Dr. Bailey and others. What are the chances of getting any of those beds reinstated that were taken away years ago? Because the major problem that we have, someone is found incompetent to stand trial, and we issue the order, but they cannot be picked up to be taken to the hospital because there's no beds available. Is that something that your committee is looking at? Because, you know, for example, in Rome, when that was shut down, that was 60 beds that just went away. So is that something your subcommittee is looking at? Because in conversations with judges around the state of Georgia, that's a real issue, not only for us in rural areas, but in urban areas as well.
I don't think that there's any question that we need more beds, a lot more beds, both on the forensic side and the adult mental health side, because this is a huge problem. You know, this is not directly related, but I just wanted to give a sense of scope to this. Nationwide, it is estimated that 1.8 million people with serious mental illnesses are booked into jails annually. You might have heard that on the Steve Leifman video. But he didn't go on to say that on any given day, 500,000 people with mental illnesses are incarcerated in jails and prisons. Considering that as of 2016, there were only about 20,000 beds in civil state psychiatric hospitals, this means there are 25 times as many people with mental illnesses in correctional facilities as there are in all civil state treatment facilities combined. We are woefully under-resourced in the area of beds. And I don't know that we need a committee recommendation to make that acknowledgement and recommendation.
Thank you, Judge. We have several comments or questions from online commission members. Dr. Johnson, I believe you may have had a question that our research folks are working to get an answer to, but if you want to state that, there may be someone on the commission that also may have that answer. So Dr. Johnson.
Thank you. I found this so interesting. I actually came up with multiple questions. One is, I think the one they're researching on is just getting us some real per capita expenditures on mental health in the state, where we rank, you know, what they're doing in the state ranked 25th. But moving right along, because I know the research team will get that, civil commitment. As you know, and really appreciate your insight and just reminding us that we now know for a fact that when people are psychotic, they are sustaining brain damage. And that 3, 4, 5, 6 episodes of psychosis is permanent brain damage, which of course increase cost as well as is devastating for that person and all the family members that relate to them. So I wondered, Dr. Stettin, if you had looked at this whole issue of being able with somebody who is psychotic, so they're not in their right mind, going ahead and giving them that long-acting injectable antipsychotic and postponing the not guilty by reason of insanity civil right issue till they're actually sane, because they certainly are not in their right minds at that psychotic moment. Do you comment on that, or What do you think?
Yeah, well, I should first of all just make clear to everyone that I'm a lawyer, not a doctor. So
Well,
I don't want to go above my pay grade by giving any kind of medical opinions. But certainly long-acting injectables are a huge, it's just a big part of the solution of how we get people who have trouble with executive functioning, just being on a treatment regimen on a daily basis, how we get folks to a place where that's one less thing they've got to worry about every day is taking their meds. So yeah, we think there's just a long way we can go in making their use routine. And they certainly play an important role in AOT. We have many people around the country on AOT for whom compliance with the order is a whole lot easier because of the use of LAIs. So absolutely part of the puzzle.
All right. Next, I believe Judge Harris.
Yes, thank you. And I just want to say to Mr. Stetton, I am 100% supportive of this. There are a couple of things that come to mind since I'm the one person in the position of dealing with inpatient and outpatient commitments. Number one, funding. What I have found, at least locally and in talking to other area judges across the state, is that a lot of the services that are provided, they are fee for services. So they do not have money for attorneys. And there are rights that have to be given, habeas rights, all sorts of things, even in the civil arena, when you're essentially taking someone's rights away. Number two, my question to you is, have you looked at the difference in the delivery system between New York and Kendra's law and Georgia? I'm guessing and looking at the feed on the chat that there is a difference in that delivery system, which, to answer Dr. White's question, which says, why isn't outpatient treatment being used as much here, or mandated outpatient treatment, I believe it's due to our delivery system. I think what you'll find, Mr. Stetton said this, that we do have mandated outpatient treatment. It is not commonly used except in the state facilities. There are a few judges that have able to work out a few things with private facilities where they've made it work, but very, very limited. So the state facilities have lawyers, funding, and they've been able to use it. But when you get out to an area where I am, 150,000 people in Bibb County, we don't have a state facility. So there are lots of questions in that delivery system. So I'm wondering, that was a long way of saying, have you looked at the comparison of the two?
Yeah, thank you so much, Judge. And I will say I appreciated our recent opportunity to speak privately. I learned a lot about Georgia's system from our recent conversation. There's no question that what was accomplished in New York had a lot to do with there was money attached to the enactment of Kendra's law. $30 million a year was infused into New York State's mental health system. But it's also, I think, important to recognize the difference in the law there, which is that we were able to create a statewide mandate, really something we've accomplished in no other state, right? Part of Kendra's law says that every county shall have this program. And so to prevent that from becoming an unfunded mandate, we really had to make those funds available to build that system of community-based care such that there was something meaningful to court order a person into. I recognize that might be a heavier lift in Georgia because it's been a heavy lift everywhere else we've tried to get that statewide mandate in place. And so what we have suggested instead is something more modest, right? If we can just prove from a fiscal point of view that the investments in this pay off, and we just know that they do, by creating a much more modest competitive grant program where we just have proof of concept in a couple of counties, it's going to take some money. There are some upfront investments that it takes to make this work. No getting around that. But if we can do that on a small scale in a couple of places, I think we can, that's to me just the first step in creating a groundswell to eventually having statewide implementation, because people are going to take notice of that. As far as the need to, the difficulties of making this work in a place like Macon where you don't have a state hospital close by, where people are sent further away to get their inpatient treatment, as you and I discussed, there's no question that makes it a lot harder to move somebody directly off an outpatient commitment to an inpatient commitment in their own community, because you've got to coordinate with a facility that's far away, that's actually doing that discharge planning. I would say the places to, it can be done. I mean, AOT is just much less challenging to implement in places that have people coming out of local hospitals. And so I would probably want that to be one of the selection criteria in figuring out where to try this first. Let's go for the lower hanging fruit. Attempt this in a place that has people receiving inpatient care locally. Try and prove this under more optimal conditions, and then figure out later how to do it in more challenging places.
All right, thank you. And I think it's clear that, and I think Dr. Vinson mentioned this on the online chat, that New York had a much more robust underlying system even when Kendra's Law was passed, so the opportunity was there. One of the things I think that would be important too, Judge Amaro, is working with your Superior Court judges and maybe Commissioner Fitzgerald and others over the next week or two to give us an idea, to give me an idea as we start talking about specific recommendations to make in the annual report. What kind of dollars would it take in a grant program to be awarded to a judicial circuit to be able to fund this in the correct manner? I think that's going to be important because I think that we have several on this commission. Judge Weaver here with us in person is an example. Very innovative Superior Court judges who are doing some very cutting edge things. If they had the right resources, they could do more. But what does that dollar amount look like? I think is going to be important. So if you could work with maybe Justice Boggs and the other judges and give us what that number looks like, that would be helpful.
Thank you, Chairman. We'll do that right away. The last thing I wanted to say, and this is a segue really, I guess, to the next speaker or set of speakers, is that by making the presentations that we have, in no way do we want to in any way denigrate the incredible work that's been done by Justice Boggs and by the accountability court community in Georgia. While I don't think it's ideal that to have folks criminalized to get treatment. In fact, we should not do that. That adds insult to injury. I think that the systems that have been put in place by the accountability courts in Georgia are unrivaled anywhere else in the country. They are fantastic. Our judges are doing a phenomenal job. Their hearts are full of compassion to doing the right thing every day, week in, week out. And I'm so impressed with them, with Judge Weaver, Judge Goslin, and hopefully we'll hear more about that shortly.
All right, we've got two more quick questions or comments from folks. Karen Bailey, question. All right, we'll come back, try you one more time, but Dr. Brenda Fitzgerald.
This was such an interesting presentation. Thank you so much. My question is about, my committee's heard about psychiatric advance directives. And that is when a patient is in his right mind, he can sign something, one, giving access, agreeing to treatment. And my question is, in this situation, if we fully incorporated psychiatric advance directives in Georgia, could that short circuit some of these things? So like, for example, when and it can be decided not only by that person, but by an assigned power of attorney or power of treatment, as you will. Would that help, or have you seen situations where those occurred and did it help?
Yeah, thank you so much. It's an important issue. We, as an organization, the Treatment Advocacy Center, are foursquare in favor of psychiatric advance directives. We think they have an important role to play. I don't feel that they short circuit the need for AOT, only because, you know, the PAD only really comes into play at a point when the person is in crisis and lacks the capacity to make treatment decisions in that moment. And so now we look to the PAD to see what the person has said they want us to do about this situation. the point of AOT, the purpose of AOT is to prevent a person from getting to that point, right? So it's a great thing to have a pad in place in case it happens. But the role AOT will add to that equation is, let's avoid the situation where we even have to open up the envelope and read that pad, because we're going to keep this person with capacity to make their treatment decisions. I'll also say, where someone has a pad that they've executed, I think it's really important to incorporate it into the treatment that's developed in the treatment plan that's presented to the court. The treatment should always be developed in collaboration with the person. What that person feels works for them, what they want is, I mean, there's nothing more relevant in figuring out what we want to court order the person to do. So we have to take those views into account, and we should build the treatment plan around what the person says works for them.
Thank you.
Sure.
All right. I know that we have an online chat going that's goes on here among commission members, also from our online folks. Is there anyone else online, and I'm going to turn the audio on online, that has any other questions or comments on this topic before we move on?
Yes, I do. I'm Dr. Dewan White, a medical director at of the Psychiatric Emergency Services at Grady Hospital here in Atlanta. And definitely agree that it's great that we have this involuntary outpatient commitment on the books, but just thinking about the implementation of it, a couple of questions that I have are regarding actually the community providers knowing about it. Is there a system that was placed in New York or otherwise where people within the emergency services or in other outpatient clinics can know that a patient has this AOT order when they come in? And also just the partnership with either CSBs or community mental health clinics. Are there specific locations that have that partnership that do AOT, or can any provider be a part of that?
So to answer the second question first, the programs are generally administered by county public mental health agencies. Bringing in community-based providers as partners to actually be the providers of the treatment day to day. So yeah, we certainly want to, we don't want to really change the nature of the person, change the nature of the treatment the person would be getting otherwise. If we have, really great community-based providers who offer the services a particular person needs, that's exactly who we want to plug into that AOT plan. But we do want to have one person in the role of not being on the treatment team, probably someone who works for the court or works for the county, who has the role of monitor, that is a liaison between the court and the treatment team, who's actually checking on a regular basis to make sure both parties are upholding their end of the bargain to each other and reporting back to the court. So, that's not a role I would give to someone who's involved in the provision of services itself. You need someone a little bit removed from that. But absolutely, community-based providers are critical to making this work. Your first question, I think, was about just getting the information. Do you mean the information about the fact that a particular person is under AOT at the point when they come into the hospital?
Correctly. Just in the emergency services that I work in, we get people from everywhere, either police bring them in, they're being ordered by various judges on an order to apprehend, et cetera. And so when we're linking them to various services or thinking about initiating an involuntary outpatient order ourselves, we don't know if that order is on or from county to county or from state to state. How do we kind of follow that through?
Yeah, I mean, I do think it's a place where there probably could be a lot done that I'm not really aware of happening elsewhere in terms of creating kind of an electronic health record that follows a person into the emergency room, such that, you're able to quickly get some information on the fact that they're under a court order elsewhere. But, not so much in the moment that a person is in the ER, but certainly within a reasonable period of time, if a person is under AOT and they have intensive case management, which is attached to that treatment plan, it is going to be somebody's job to know that that person's been admitted to a hospital, at which point, when that case manager becomes aware, they should certainly let the treatment team in the hospital know that this is a person under AOT and just fill them in on whatever the implications are of that.
All right, thank you very much. I want to try one more time. Karen Bailey, are you with us? Did you have a question? All right, your audio's not coming through, Karen. If you have a question, if we can't hear you, if you want to type that, we will try to ask it for you. One of the things too, I wanted to make sure all of our members knew, I know our judges know, but the involuntary commitment, the 1013s, it's being referred to, probate court has jurisdiction over those here in Georgia. So when those are done, they go before a probate judge. So I think that's an important distinction here also. I believe Ms. Bailey's question was, when New York implemented Kendra's law, they made a significant financial investment. Can you tell us the amount of money that was attached? I believe that was $30 million is the answer to that. My understanding, and it says, my understanding is a critical key to the success was the funding monitoring component to ensure the community agencies could and do actually provide ordered treatment. So I believe that was $30 million. And I believe you are correct in what you're saying there, Ms. Bailey, that it was in the important part of it was the follow through. All right, we're going to move forward. We've got, we're going to move forward. We've got several other things that we need to get to. So we'll have to save any other questions on this topic to the end. Judge Amero, again, thank you very much for your presentation, for all your hard work. All right, next up, Justice Boggs has been chairing our mental health courts and corrections. Justice Boggs also led the effort for the state and for Governor Deal in criminal justice reform as chairman of that committee that worked diligently and has made tremendous improvements around the criminal justice system in our state. So thank you for all your work, and Justice Boggs, we'll turn it over to you.
All right, Mr. Chairman, can you hear me?
Yes, sir, we have you.
All right, I'm going to share my screen now. A couple of points. First, thank you, Mr. Chairman, for the opportunity to present on behalf of the subcommittee, the Mental Health Courts and Corrections Subcommittee. I do want to make a couple comments about past presentations. First, Dr. White at Grady raises a very valid point. It's not only the lack of all this siloed information that is contained in 159 counties and different courts across the state relative to AOT orders, but it is also information concerning psychiatric advance directives, right? I mean, these folks travel and these folks are in different parts of the state, and we've encountered the real significant practical difficulty that Dr. White highlights right here in Grady, that they get somebody and they have no idea whether these folks are under any court order whatsoever. And so that's something that we're all acutely aware of. Secondly, with respect, Mr. Chairman, to your request that we come up with some numbers relative to maybe a pilot program on AOT, you mentioned doing that in a circuit. I would suggest to you that maybe we do some representative circuits for rural and urban circuits relative to getting a more representative example of what's going on in the state. We've done that in other measures across the state, and I think a more widespread representative sample of circuits would be helpful there. So I look forward to working with you and whoever's involved in that to come up with a cost for implementing that. So now I will tell you that I'm very impressed with Dr. Fitzgerald and Gwen Skinner's presentation. Those presentations I think highlight a really interesting thing for me as a judge in particular, but also as a citizen in Georgia, that an inadequate or unavailable mental health service delivery system, whether it be through short-term care facilities or hospitals, exacerbated by a workforce development problem, really results in a manifestation of these things in our court system. And Judge Amero, I think, really illustrated that best with his vignettes. Those are not, unfortunately, really, you could probably get one of those or two of those or five of those in any of our 49 judicial circuits at any time that you'd like. Unfortunately, they are more widespread than you might imagine. And so when these matters manifest themselves in our criminal justice system, it also highlights, I think, the importance of data, the lack of these data, and the key that you pointed out, Mr. Chairman, that what we really all want is evidence-based informed decision-making. It's really hard to do that when you don't have the data that you need. And so I'm very appreciative for the hard work that apparently these other subcommittees are working on. I want to make a presentation today that'll be followed by a presentation by members of the Council of State Governments Justice Center on some supervision work that they're doing with our Department of Community Supervision. I'm going to start with a brief highlight of the agencies that we've heard of and some real key talking points and takeaway points from the various presentations that they've made to my committee. I will tell you that the full presentations are available. If anybody wants these agencies' full presentations, I will make those available after the meeting. I think Chelsea has copies of them anyway, Mr. Chairman. So my presentations are by no means an exhaustive review of what we heard. My committee members, as the slides suggest, Judge Amero, Judge Brenda Weaver, and Judge Kathy Goslin, who all well understand not only the problems that we have in the criminal justice system where these unaddressed issues manifest themselves, but Judge Goslin is president of the Accountability Court Judge Council, as Judge Weaver has formerly been, and I know you've just heard from Judge Amero. Fortunately, we also have law enforcement representation with Chief Dekmar and Sheriff Andy Hester, and you know their credentials and how influential they are and how interested they are in these particular issues. And then Stan Cooper, of course, is formerly with the Georgia Department of Corrections and as a liaison and still does work with the Department of Corrections. We've had 3 meetings on February 25th in person. The other 2 on May 26th and October 7th were virtual meetings. We've had full participation by all of our members. I really appreciate the robust conversations and the input that they've all provided as we've heard from our state agencies and the challenges and barriers that they all face in delivering adequate services to the populations that they serve. Lastly, I'll tell you that we've heard from the Department of Corrections, the Department of Community Supervision, the Georgia Department of Juvenile Justice. We've heard from Terry Norris and the Georgia Sheriff's Association, including mainly a presentation from Daugherty County. I'll show you a snapshot of what they've given us. We'd heard from Georgia's Accountability Courts Council and specifically matters on mental health courts. And of course, we've also heard from the Council of State Governments Justice Center. So those acronyms at the bottom. I'm now going to start with this conversation about what were the takeaways from each of these presentations so you have a better feel for the nature of the problem that is in the criminal justice system in Georgia. And I'll start with the Department of Corrections. So I'm trying to move the slide and it's not working. There we go. So as of January 2020, this is what the mental health population was in the Georgia Department of Corrections. The overall population was 53,694. Their calculated mental health population was 12,009. They, of course, level them based on the severity of their and nature of their persistent mental illness. Level 2 was at 10,241 and made up almost 18% of the entire Georgia Department of Corrections population. Level 3 was about 2.4%, and then level 4 was the more serious ones, which were less than 1%. I will tell you, I've got some updated data as of just a couple of weeks ago. As of December 20th, the Georgia Department of Corrections population is down 11%, believe it or not, from January. We all know why, I suspect, but from 53,694 down to 47,781. So there's been a pretty significant decline in the number of individuals committed to the Georgia Department of Corrections since January. That has changed, of course, the population percentages with severe persistent mental illness. The level 2 numbers now comprise 9,186 of the total, which is 19.7%. Level 3 is 1,305, which is 2.8%. And the level 4 is still relatively modest at 344, which is less than 1%. So that's a picture of your Georgia Department of Corrections and who's there. This is how their population has changed over time. If you look back to 2001 and the total number of individuals in the custody and care of the Georgia Department of Corrections and how that number has changed, you see a pretty precipitous increase. These are a breakdown of who's there. 14% of their male population receive some mental health services, 55%, not surprisingly, much higher incidences of behavioral health issues within the female population. 55% receive mental health services. 85% of those that are males receiving mental health population services are level 2 offenders. 98% of the female are level 2. That shows the breakdown by graph. and also the breakdown by who's receiving what level of services. So some of the challenges in the mental health population that the Department of Corrections deals with, as has been illuminated by the Workforce Development Committee, is staffing shortages. Staff shortages within the mental health workforce generally, having a very difficult time recruiting qualified staff to facilities, particularly facilities in rural parts of the state, where there is a certain bias towards the correctional environment to begin with. So staffing challenges are not uncommon to any of the folks that you're going to hear from today that have reported to my committee. In addition, they need and have had really difficult concerns and have developed strategies and tactics to try to recruit a forensic psychologist, strengthening their suicide risk assessment programs, their multidisciplinary suicide prevention teams. They're trying to promote a suicide hotline and mandatory staff training on mental health. And so they provided outlines of all of their training to our committee. I was impressed with the amount of training, both CIT and otherwise, that they're getting. But these all present very serious challenges to the Department of Corrections in delivering services to those that are in their care. And currently, as you might imagine, there are some very limited treatment services for the dual diagnosed offenders. Those are, of course, those with mental health and substance use or abuse disorders. Part of that is attributable to a rise in the opioid crisis in our state and in our country, and has manifested itself in more individuals with that problem being committed to our state prison system. When we're dealing with very acute mentally ill offenders, the long-term hospitalization treatment is really required, but those services aren't available within the state of Georgia at all. And so we have a very difficult time with long-term hospitalization for any of those that have a level 6 or otherwise. Some of the recommendations that we heard from the Department of Corrections include evaluating the viability of a long-term acute care psychiatric facility, which is the reason that they raised that as such a big problem. And that is really sorely needed in this state, and we simply don't have it, Mr. Chairman, and that might be something we talk about relative to a funding or budgetary appropriation. Next, evaluating the viability of expanding integrated treatment within the Georgia Department of Corrections facilities for those offenders with mental health and dual diagnosis. They've opened up some co-occurring disorder facilities, one for male and one for females over the last few years. I know that our accountability court judges are using those, as are others, in the nature of probation detention centers, as I recall. The other concern, of course, is the need to increase the availability of forensic peer mentors for those offenders who are preparing for release from prison. That is a joint effort that they're working with DBHDD and the Department of Corrections. But forensic peer mentors are a very important concern for the Department of Corrections. And of course, the real problem, and we see this relative to reentry generally and problems with lack of wraparound services, is the need to ensure continuity of mental health care and connectivity to those individuals that are being released from prison every year. I don't have the exact number, but we're releasing probably close to 18,000 people a year into the state, into the community. We use transition centers for a bulk of them, but having wraparound services and returning them to the community in the communities that they're going to return to is very difficult, particularly given the lack of available mental health delivery systems in very rural parts of this state that I'm familiar with intimately from my work as a Superior Court judge in the southern part of the state. Next, we heard from the Georgia Department of Community Supervision. As you know, criminal justice reform basically combined the supervision of the Department of Corrections, which heretofore had obligations to supervise all of our felony probationers in the state, along with parolees that were under the supervision of the Georgia Department of Pardons and Paroles. So we now have a new department, the Georgia Department of Community Supervision, that deals with monitoring and supervising and providing services to the many people we have on community supervision in this state. Just to give you some kind of idea, this is how many people we're looking at: 18,555 people currently that have past or present mental health needs that are on community supervision in this state. 16,321 have been identified and had referrals made for services. 2,557 are on specialized caseloads, which are really difficult with the staffing shortages that we have at DCS and the ratios that we have at DCS relative to the number of individuals that are under the care and supervision of a particular probation officer or parole officer. In addition, as has been illuminated by others, we have problems with homelessness and mental health problems and getting individuals into housing. 244 of the people that we're dealing with on community supervision in the state still have housing challenges. I'm sorry, 243 have housing challenges. So some of the gaps that have been identified by the Department of Community Supervision and Michael Nail, who's the director or commissioner, is a lack of funding, again, for forensic peer mentors. It's huge staff problems at DCS. They've got staff retention and turnover problems, which obviously when you lose staff that have developed a rapport and relationship with individuals that they have under their care and that person leaves, that individual that is on probation or parole is having to now start afresh and anew with someone new. That break in services can really create problems that we see resulting in a lot of probation revocations. Funding is still a problem for services. And as you might imagine, in a state as large as Georgia, with 49 judicial circuits and 159 counties, we have still transportation issues across the board for these individuals to even receive services to the extent those services are available. Continuity of care, we talked about in the Department of Corrections, but it's not uncommon here either, is that we need really seamless collaboration with the CSBs, the regionally located CSBs, and behavioral health providers. It's very difficult to establish that seamless collaboration because people move in and out of the system. But that has been a very difficult challenge to provide continuity of care for those individuals. And we have a couple 100,000 folks on community supervision in this state at any given time. And there's a long wait time for individuals who are referred for services. So even where we have services, getting them timely services so that they don't violate terms and conditions of parole has been an enormous challenge. Next, I want to move to mental health courts in Georgia, a really positive thing here. And I really appreciate Brian Stetton's presentation on AOT and how we might fold AOT into our problem solving or accountability court models that we currently have in place in Georgia. That's something that I'm very interested in, and I believe AOT, while not a panacea, is certainly an opportunity to maybe expand the reach of our mental health courts. We have greatly expanded the number of participants that are being served in our courts from fiscal year 14 to fiscal year 19. You'll see the huge increase. We've got 22,112 participants that were served in FY19. As you know, the ROI, the return on taxpayer investment dollars that is spent on treating these individuals in a diversion program like our mental health courts saves an estimated $6.03 saved on each dollar spent. Each representative of a mental health court represents $16,543 in diversion savings. The Carl Vinson Institute at the University of Georgia conducted a study recently, an economic impact study of the impact of accountability courts in Georgia, and by virtue of keeping individuals out of prison, obviously, which is very expensive, and less impact on courts and with law enforcement, less reliance on foster care, less reliance on our emergency departments. The savings are astounding, $34 billion for the graduates that graduated just a couple of years ago. Recidivism is also important, and right, public safety is something that we should always the criminal justice systems should be concerned with, and I know our judges are concerned with. Folks that are involved in our mental health courts recidivate at a much lower rate than those that are not involved and go through traditional adjudication. So for our postgraduates, 12 months out, 16% have been rearrested and reconvicted. After 24 months, 24%. After 36 months, about 32%. So, and that's for those graduates of the program. Here's where our mental health courts are located in the state to give you some geographic representations of where they are. We have now, I think, have an accountability court, not necessarily a mental health court, but an accountability court in every judicial circuit in the state. Our judges have really stepped up. I'm really proud of the judicial branch for really stepping up in a place that was sorely needed. And you can see that geographic representation. But too, they have challenges. Funding is probably first and foremost. They really need consistent state funding, especially in the rural areas. That has always been a challenge with mental health courts. They're funded, you should know, from myriad of sources, but predominantly from fees generated by the individuals that are on supervision. Also a state grant program, which was cut last year. We hope to get that restored back to its regular levels. So there's some budgetary appropriations that we're going to be looking at to help fund mental health courts partially through the state. And of course, some of them get some, that state grant funding typically comes through the Department of Justice, Bureau of Justice Assistance down to our state. And of course, one of the big challenges is that lack of available mental health services in the communities in which these individuals are being involved in the court system. So community service boards are the predominant service provider, as well as DBHDD. There is a lack of awareness. We need more awareness among the stakeholders and more of a sequential intercept model, I think, to help make those programs a little bit more effective. And we need more treatment providers. I mean, the bottom line is that in many parts of this state, there are disparate resources available between the metropolitan and urban parts of the state. And it has been a challenge for our mental health courts, particularly in our rural areas, to provide resources and treatment for individuals that are under their care. Housing is always a problem in the criminal justice system writ large, but also for individuals that have mental health problems. And so a lot of these individuals have a lack of access to appropriate housing. And because of that, including public housing and restrictions on folks living in public housing in many places that by virtue of having a criminal history, they're just simply not available. And so we have providing stable housing to these individuals is not only crucial to their success, both inside and outside the criminal justice system, but it is not available for many of them. Transportation continues to be a problem in rural parts of the state, as it is, as we've seen with the Department of Community Supervision. These individuals in mental health court have myriad obligations to come to court, to be involved in assessment programs and treatment programs provided by their mental health courts, but getting there is a very difficult problem. And then medication assistant treatment programs that have been shown to improve outcomes for some of the substance use dependent offenders. Those are limited around the state, but we see some continued but improving stigma on some of that as well. Data collection is a problem with mental health courts. We are fortunate that the legislature years ago provided some money for verification programs and certification, peer review certification programs, but that money has been cut recently. And so we're not able, the mental health court programs are not able to provide the certification programs that they had been providing to ensure the accuracy of their deliverables. So all of that is important, as well as obtaining more assessment and treatment programming and court training programming. One of the here's a list of recommendations made by the Council of Accountability Court Judges for mental health courts. More funding for gender-specific trauma treatment modalities and curriculum. Funding to facilitate the gender-specific trauma treatment and accountability courts serving mental health and or co-occurring disorder populations. So we have mental health courts and we have drug courts and we have some hybrid courts that are doing both and have co-occurring populations within their charge. Next, funding for a dedicated Council of Accountability Court Judge position to provide technical assistance to courts to interpret their court data to support changes in best practices and deliverables. And then the 15-21-101 is the DATE statute. That is an acronym for Drug Abuse Treatment and Education Funding. That is funding that is generated, all fines that are leveled against all felony and misdemeanor criminal defendants in the state. Right now, that money that is generated is used to support a lot of drug courts, family treatment courts, and other such courts, but has not been, that code section has not been amended to include mental health courts. So there's a request by them that statute be amended to include a mental health court division could receive funding from DATE funds from the state if available. So Albany, Georgia, Daugherty County gives us a snapshot of what's going on in our county jails. And I know Chief Deckmar can speak more to this if you have questions, but he talked about an issue that I hope you all didn't allow to go unnoticed. And that is an individual that his agency has dealt with on 70 different occasions that I believe he said resulted in at least 12 different arrests. You know, our jails become the de facto mental health institutions in a lot of our communities. It is not only morally unacceptable, it's financially and otherwise not sustainable. And we've got to do a better job of getting these individuals the treatment they need and not putting them in the county jails. Judge Amero's vignette pointed out that in even a more significant way. But even in Daugherty County, they show that inmates undergoing mental health treatment They had 209 people in the Daugherty County Jail at the time they presented this to us, which made up 35% of the entire population. 25 people were in mental health segregation, which made up 4%. And of course, only a few in state hospitals because of the lack of beds. So this is but a snapshot, but Daugherty County is representative of jails across this state where judges are really tasked in many instances because the lack of resources in their communities. They have nowhere else to put individuals. And because individuals could be dangerous or might have exhibited signs of dangerousness to others, judges are awful cautious about that. And in many instances are left with no choice but to place these individuals in a county jail. And county jails are just become really inundated with this population, and they're least able to deal with them, particularly in rural parts of the state where even if they have them in the county jail, they don't have resources for them. So this is what the Daugherty County Jail Sheriff's Deputy suggested we look at. Obviously, alternatives to incarceration for pretrial inmates is something that our committee is looking at. Diversion programs in both, not only pretrial diversion programs, but even pre-arrest diversion programs, something that Chief Deckmar is familiar with, programs that I'm familiar with across the country. That pre-arrest diversion simply means instead of the arrest, you divert that individual to a program that can treat and maybe alleviate their program, with the reward being maybe that the arrest never happens. And then, of course, developing treatment resources on a regional level. That is something our law enforcement really wants, because they simply don't have resources now. Department of Juvenile Justice presented to us. We were happy to hear from Dr. Doyle and Margaret Kaywood. Really appreciate the commissioner for making them available to our committee. They made some presentations that I don't think you'll find surprising about the status of the behavioral health issues within the Department of Juvenile Justice. Here's a snapshot of what DJJ looked like when they presented. They have 97 community service officers dealing with about 10,000 plus youth. They deal with intake and case management, probation, reentry services. There are 25 secure facilities in Georgia. Many of you have these in your communities. 6 youth development campuses, commonly referred to as RDCs or YDCs. 19 regional youth detention facilities, 1,200 plus youth, plus 850 in the RYDC, and they have about 3,500 employees. So that's kind of the overview of DJJ's current resources. They tell us that national data indicate that up to 70% of youth involved in the juvenile justice system can be expected to have a mental health need. That comes from the Department of Justice's Office of the Office of Juvenile Justice and Delinquency Prevention report. They also tell us that youth with mental health needs may have less positive outcomes for their juvenile justice involvement due to lack of treatment resources and other factors. So OJJDP lays these data out for us to further inform our decisions. That's the caseload that we've seen at DJJ on admissions, average daily populations, average daily mental health caseloads, and percentages. So you can see a very large percentage of mental health caseloads at both the RYDCs and the YDCs. Very significant numbers of individuals, youth, that are being housed in our facilities that need services. Their challenges, again, are recruiting and retention of qualified staff, including psychiatrists, psychologists, clinicians, and counselors. They do not have, which is obvious to most of us, competitive salaries, and that has been an impediment and a barrier. There is a lack of a statewide lack of qualified staff, of course, affects their ability to recruit. And the impediment of getting individuals to come to rural areas of the state has always been a problem for DJJ, as it has been for other state agencies. COVID has highlighted for them a very significant number of staff who will be retiring within the next 5 years. And so we got to be thinking about not only their aging workforce and how we replenish that. So I'm really hopeful that the Workforce and System Development Subcommittee can give us some recommendations that will help the Department of Juvenile Justice. Some internal challenges and resources. Because of the economic downturn, treatment service budget cuts were never restored. There's been some juvenile justice reform through Governor Deal's Criminal Justice Reform Commission that has diverted money to other programs, worthwhile programs nonetheless, but it has had a financial effect on the Department of Juvenile Justice. Evidence-based training has been assessed when possible through partnerships, but specific resources have never been allocated to support evidence-based programs. Evidence-based programs are obviously the most promising, have been studied, have been validated, and have proven to work. And that's, of course, what we want all of these folks providing to the extent they have the resources. They also have demonstrated and relayed to us their concerns about limited treatment resources available in the community, especially in rural areas. I know this is starting to sound like a broken record, but all of these state agencies have this issue. Lower risk youth are being pushed unnecessarily deeper into more expensive residential and secure confinement. There is a huge insurance and funding stream gaps that have been identified by DJJ. That's been an impediment to getting services to these individuals. And then, of course, clinicians often have difficulty linking youth to the necessary services when they return home, again, highlighting the need for better and more collaborative relationships with local service providers, and in fact, having local service providers to make sure we have good reentry wraparound services to individuals. There is an alarming amount of insufficient residential programming bed capacity to meet the needs. So the wait list for medium need risk youth is very high. Denials from current providers for DJJ higher risk youth has created a problem. And there are a lot of placement failures and disruptions. So as they've tried to place individuals, they've recognized lack of resources and lack of people willing to take some of the higher risk individuals. So I'm going to finish up now with this slide and then turn it over to the Council of State Governments Justice Center to present on what their program is going to be and what assistance I expect they will provide us. But just to give you an outline, CSG via Angie Gunner, who is a senior research associate, and Alex Blanford, friends of mine, folks I've worked with for years, are going to present to us on basically the challenges on how they can improve the outcomes of people with behavioral health challenges on supervision. So we talked about the Department of Community Supervision. I highlighted for you the representations that they made to my committee about what some of their challenges are going to be. Essentially, CSG is going to take an opportunity to hit these highlights, which is first, identify opportunities to increase identification of this population, right? So coming up with common definitions, screening and assessments at jail or in jails across the state, and information sharing, again, to Dr. White's point at Grady, sharing this information across boundaries. In addition, opportunities to divert people, and we look at, as I talked about earlier, pre-booking, pre-arrest, pre-charge, and pre-conviction diversion programs. And then lastly, opportunities to increase availability of care. So CSG is really going to come down and give some technical assistance on what can we do to better improve outcomes for this huge population that we have that Commissioner Nail and his agency are charged with monitoring and ensuring compliance with court orders that judges across the state have entered in placing people on probation and giving them conditions of probation. So with that, I'm going to now turn it over, Mr. Chairman, to Alex Blanford at the Council of State Governments Justice Center, and I think she has a presentation to make as well.
Thank you so much, Justice Boggs and Chairman Tanner and the members of the commission for having us here today. My colleague Angie is going to be sharing her slides momentarily from her machine. So hopefully she can do that successfully at this juncture. But while she's doing so, probably no introduction because Justice Boggs, you did it so well. We work at the Council of State Governments Justice Center, a national nonprofit. Angie, you can go straight to slide 2. Great. And we represent state officials, all 3 branches of government. We also work very much between state and local levels and federal levels. So all branches of government, all levels of government. And within that, we focus, of course, on the criminal justice system, but where I sit is in our behavioral health work. And I'm going to be speaking certainly most to that today at the intersection of behavioral health and criminal justice. So Angie, move forward. So today, what we're going to accomplish, as Justice Boggs said, is we're going to, I think there's actually been such a wonderful job in giving an overview of the problem through the other presentations that I've heard. I'll just hit a couple additional points and actually give you just a little bit of context about Georgia specifically as it relates to the overarching problem. But then we're going to move really pretty quickly, in the interest of time, to talking a little bit about these policy priorities that we had brought to the subcommittee for consideration. And we'd organized those in 3 different ways. So first, identifying people with serious mental illness. So you need to understand the full scope of the problem, and you need to understand it's not a heterogeneous population. So understanding what the needs are, what the scopes of needs are, how these individuals are flowing in and out of the system in order to really direct responses to what's really going to move the needle and reduce their prevalence. And then the second, and that area actually encompasses a lot of information sharing too, and the role of data in accomplishing that. The second policy actually is focusing on that information sharing across systems. That remains a challenge. And the last one is going to be focusing on opportunities to connect people to care and services, which is so critical. So Angie, if you can move to the next slide. As everyone has heard, I won't spend much time on this slide, but just to show you some of the national numbers, people with behavioral health conditions are overrepresented in prisons and jails. You can see that is even more so when looking at substance use disorders as compared to serious mental illness. And overall, incarceration has that detrimental effect in severing ties to essential benefits and providers if people were connected even in the first place, that results in really poor access to needed care and services and an over-reliance on costly services. And if you could go to the next slide, Angie. And why are we talking so much about jails? I think Justice Boggs, you already set me up beautifully for this. We're talking about jails really as the marker of really the proxy of how a community is doing on this issue in terms of how many people with serious mental illness are in these local criminal justice systems. And we also look at jails in particular because, as you can see, the numbers are really astounding, in particular in terms of jail admissions to prison admissions. And that's true even in Georgia, as we're going to see on the next slide. I have some data from Macon-Bibb County. Oh, you can see that right here. So as you can see here, the numbers are high. I want to point out in particular the average length of stay. The average length of stay is twice as long for people who had a mental health diagnosis than those without. I think that's incredibly critical to highlight here. Some of the reasons for that relate to their ability to be diverted pre-trial, as we spoke about a little bit just now. And many of these individuals, I think, what's most important to remember is that a lot of these individuals do not pose a significant public safety risk. And there's some research and studies that we can share to illustrate that in action. But what that instead represents is, if you can imagine, these individuals are sitting in jail, not the right place for them to be getting the care and treatment. It's costing money for them to be sitting in these facilities. Every day that they're losing access to housing, to their benefits, to their care, to their families, their services, their networks. And so I think that's a quite alarming trend when we look at, not only are there high numbers that are being booked in the first place, but they're staying longer. And then, as you can see here, they're also returning at higher rates. So when we think about our sort of overarching set of recommendations, what we had put forth to the subcommittee was really thinking about how can you keep people out in the first place who really don't need to be there. For those that do pose a public safety risk, thinking about strategies to, respond to them appropriately, combined with supervision and collaboration there, and then reducing the amount of time that people are in the system, and then reducing the likelihood that they return. Angie, if you could just go back to the slide before really quickly for me. I just wanted to highlight this graphic on the right very quickly. This is actually the original representation of the sequential intercept model. For those of you who are familiar, it's come up today on our call. And I like to show this version because I think it highlights a few different things. It shows sort of this volume concept of how can you create these off-ramps from the system, and thinking about what that looks like in terms of the volume of population at all of these points. And also in terms of, sequential intercept model helps us also think about, while this is the criminal justice intercept model, it's also thinking about the roles of other systems and partners and helping to facilitate those off-ramps and to get people into then community-based care and services. And so I'd like to share this because I think it's a helpful reference to keep in mind of why do we talk about early intervention? Why are we including law enforcement in this conversation? Why do we think about crisis and sort of the early upstream strategies, in addition to the ways that we need to be thinking about when people are booked, what then happens to them and through that criminal justice continuum. And as I also like to highlight in this slide, This is very, very complicated, as everyone on this call probably knows, but if you're not as familiar with all the criminal justice pieces of this, when we even talk about a criminal justice system locally, we're really talking about a lot of independent agencies and actors and entities that are working together, but are also working with their own data systems, their own priorities, their own funding sources, and that can certainly complicate the ability to have these comprehensive mechanisms and to really have these streamlined systems and ability to share information seamlessly. So Angie, if you could move forward for me. Of course, we're talking about behavioral health needs, but I want to just put a quick fine point on the fact that this population, in particular, those that we've been talking about as high utilizers or familiar faces, however you refer to them, individuals that have very complex medical conditions in addition to their substance use and mental health needs. They also have significant social needs. Justice Boggs talked about this with the mental health court community, but it's certainly not limited to those participants. This need for housing as a way to facilitate diversion, as a way to ensure that people can meaningfully participate in these programs and care. That remains a challenge across the entire country and not unique to Georgia. But that's an important thing to think about in our strategies of how we're also thinking about connecting people to care, but the ways that we think about care is also encompassing some of what the health folks call our social determinants of health. So things that can negatively impact health and then in turn can negatively impact our public safety and our criminal justice outcomes. And then of course, the last point there we already spoke to, people with complex needs and these high utilizers are arrested at higher rates, they stay longer in jail and return at higher rates, particularly for violations of community supervision conditions, which actually Angie's going to speak to a little bit as that relates to some of the work there. So despite the challenges, I just want to do a very quick plug. We are one of the 3 national partners alongside the National Association of Counties and the American Psychiatric Association Foundation that started an initiative that was intended to be responsive to this problem. How can we help communities thread all their various programs and responses together in a way that gives them a system-wide framework to help them really see what's driving the problem, and then how to work together to really pinpoint their responses to the things that are most driving it. And I wanted to acknowledge that Georgia has 11 counties that have passed resolutions committing to participating in the initiative. And the goal really is to focus on reducing the numbers of people with mental illnesses and particularly serious mental illnesses in jails. And so it's a very sort of metric oriented approach as well, which I think is very, very helpful for counties as we hear, because as you know, each sort of entity has their own measures of success. But this kind of an approach puts forth 4 common measures that can be used to guide comprehensive responses. And we're seeing progress here. I think it's great to hear what we've been talking about, sort of like what are the innovations and the progress that we already see in Georgia that we can explore as ways to scale, or what can we learn from those models? And we have some counties, Athens, Clark, for example, just through the Stepping Up work, just added a 3rd co-responder model. They're working to select an integrated data system. Fulton is also in the process of selecting an integrated data vendor. They're doing a lot of work focused on high utilizers and really targeting their energy and strategies on that population. And Chatham just opened up a crisis center, despite the pandemic. Actually, it was in the midst of the pandemic. So you can kind of see that the progress that these counties are able to make, which is very, very exciting. And next slide. And how are they able to do this? Well, it really is 4 key ingredients that we identified, and I'm sure not limited to. But the most important things are, do they have these engaged leadership and collaborative governance structures? And what could the state role be and potentially to help communities really formalize those so that, that a collaboration doesn't go away once a program is ended. So there's these very, very, ongoing mechanisms, as Justice Boggs was saying, to collect data, to analyze that data, to do joint informed decision-making across systems and actors. Then the other piece, of course, this is, again, huge need, access to quality, actionable data. I mean, we we hear again and again and again that counties across the country and communities are lacking the infrastructure to collect data, to use it, to analyze it. And so there's a lot of interest in learning from counties, such as two that I just mentioned that are looking for their integrated data systems. They're sort of our innovator counties, so to speak, under Stepping Up. They're sort of advanced in this space. What can we learn from them, and how can we help other counties not reinvent the wheel? But also, of course, the holy grail that we hear across the country is, what can the state do to help support a sort of statewide response or strategy to be able to collect and analyze and facilitate all of that work at the local level. The next piece, of course, is diversion and access to community-based care. This is two sides of the same coin. So there's the ability, there's the criminal justice policy side of facilitating diversion, pre-trial, post-conviction, at all different points. But then there's also the what does that then mean? Because it's the diversion to what question, which I'm sure is a refrain you all have heard. And it's critical. Housing remains a critical barrier. And as you said, Justice Boggs, we hear from judges, we hear from sheriffs that there's a challenge with wanting to, for someone, particularly don't pose a public safety risk or significant public safety risk, just the paucity of services makes it more difficult for them to be able to meaningfully divert someone from jail or from the courts, to be able to then have them participate meaningfully in care and services and live stably and healthily and safely in the community. And then the last not least, this is very critical, something I wanted to underscore. Communities, of course, is where the action happens. That's really where the rubber hits the road, where this work is happening, but they can't do it alone. And really I'm so heartened by this commission and this charge, because there are certainly things that the state can do to really help communities address those critical gaps that otherwise just will continue to hamper progress on this. And so they're very, very critical things. We're going to talk a little about those right now. But before we do so, I'm actually going to turn it over to Angie, because she's actually going to talk a little bit about some of the efforts that she's working on and some of what the state is currently doing that we have been involved in, and preview a new study that she's going to be working on.
Thanks, Alex. Some of this information you have seen already from Justice Boggs. This is a bit of a summary of the state of mentally ill people in the justice system. About 1,400 cases at any given time in the mental health courts are under supervision. And you can kind of look at this as being kind of in the middle of the sequential intercept model, where you have a post-initial hearing, and this is where you engage with the courts and you do evaluations. And as Justice Boggs had mentioned earlier, over the course of a year, you have over 2,000 people who are participating in a mental health court. Almost at the bottom of the sequential intercept model are the state prisons, where information was already presented on this, but about 10,600 people are incarcerated at GDC. And of those, quite a high percentage have at least a level 2 mental health diagnosis. And at the bottom of the sequential intercept model, you have people who are on community correction supervision in the community. And at any given time, you might have about 2,500 people being supervised by the Department of Community Supervision on a specialized mental health caseload. DCS has been supervising individuals with mental illness on a specialty caseload since, I believe, 2017. So they have about 4 years of experience doing this. They have also day reporting centers with co-occurring curriculum. They have a forensic peer mentor program, reentry partnership housing program, which offers assistance for up to 6 months. The specialized mental health caseload that DCS has implemented really follows best practices in terms of their caseload size and the number of contacts per month, and their focus on connecting individuals to care in the community. And we have, we proposed to DCS recently a research study to evaluate how well the Department of Community Supervision's specialized mental health caseload is performing. I'll just go to that. We received external funding, and we are going to be working with DCS on an analysis of their specialized mental health caseloads. There are two main areas of the research that we're proposing to conduct. The first area is the program fidelity. They have set up a really strong program with enhanced supervision, and their goals are to decrease the number of rearrests and to ensure treatment compliance and compliance with medications. They have a caseload design with a ratio of 40 cases to one supervising officer with 5 monthly interactions. As we've mentioned earlier, connections to the community service boards and behavioral health specialists is a key component. Access to those services is disparate across the state. So one of the areas we're going to be looking at are, rural compared to urban centers and how well, the urban centers are doing in comparison because they have many more providers to take advantage of. The other area of the analysis will focus on outcomes, and we'll be looking at number of rearrests, number of revocations, technical violations. Initially, we're going to be comparing people who have serious mental illness with the non-SMI population just to establish a kind of baseline. And then we're going to do a little bit more in-depth analysis of the SMI population. And that's to look more specifically at people with SMI who are supervised on the specialized mental health caseloads compared to those who have a serious mental illness but are stable and are therefore not on the specialized caseload. And we want to look to see if there is a difference in their outcomes. And there has been some strong research literature in this area in recent years to suggest that the specialized caseload with the lower ratio of individuals to supervising officer is very successful in addressing the special needs, the really complex needs of this population. We are kind of driving this research effort based on some recent studies out in the field of criminal justice. And I'm just highlighting here a few of those studies that have been particularly encouraging in this area. 2 of these studies are actually using the same data set, but they were looking at 2 different factors. One of the things that this study was looking at was the probability of rearrest. And the analysis found that for people with serious mental illness who are supervised on a specialized mental health caseload, they had a 28.6% chance of rearrest compared to people with serious mental illness who were supervised on a traditional caseload whose risk of rearrest or probability of rearrest was 52.8%. So that's almost half a reduction. It's substantial. With that data set, they also looked at the cost, which I think is really interesting, a really interesting study. They wanted to see, is it less expensive overall for states to engage in specialized mental health caseload supervision for, does it cost less overall to focus more intense resources upfront, and where are those savings being realized? And what they found was there's reduced recidivism, and that generates some cost savings, but the bulk of the cost savings to a state or a community is going towards reduced use of emergency services, reduced inpatient and residential treatment costs. And so when you look at the system in a more holistic view, it is important to realize that while the costs of this more intense supervision, where you're connecting people to resources and you have smaller caseloads, that might be more expensive for a Department of Community Supervision. But overall for the community, it's less expensive, and it has a high rate of return. There's another study that I just wanted to highlight briefly, and it was looking at whether people on a mental health specialty probation caseload was effective. And they found that people supervised under this model had fewer days in jail compared to traditional caseloads. And that the comparison there was, I think, 53.8 days in jail for traditional caseload supervision, compared to 38.6 days for people on specialized mental health caseloads. And so while you're still finding that some people on supervision wind up in jail on a rearrest subsequently after being placed on supervision, the number of days is reduced, the number of, and so the cost is reduced as well. So these are all very encouraging for this area. And I think once we finish the analysis and get the results for Georgia, we're going to be able to potentially make some recommendations. We'll be able to know how well Georgia is, or the Department of Community Supervision is performing in this area, and whether any additional investments are needed to maybe expand the number of people on the caseloads if that's necessary. Or there are many things that we might discover after the analysis, but I think it's definitely worth doing. We're really excited about getting started. And we've got the data sharing agreement in place, and we've ready to get started on that. So I'm going to pass it back to Alex for the policy priority areas for consideration in the criminal justice arena. But we can always come back to this with questions at the end.
Great. And Angie, get your finger ready because we're going to go through these pretty fast in the interest of time. So I put forth some various policy ideas, and we're going to go through each of those within these priority areas. So the first one, you can go to the next slide, Angie, is developing a shared definition of serious mental illness. This is really, really helpful, not only to ensure that you're able to compare apples to apples in terms of data across communities, across counties, across agencies. It also ensures that there's eligibility of service issues that are consistent, and helps establish that common metric to know if you actually have your prevalence rate and what's moving it up and down. So in terms of things the state could do, it could assess existing definitions and ways to align, could require the use of a shared definition. I'm not sure how that would go. That's an idea. And issue guidance and provide support for adoption. If you go to the next page, next slide, Angie, there's a couple of examples here. We'll make sure these slides are available in case you want to read more about the examples and click on these links, but just know that there are some states that have moved in this direction and are taking on these efforts. Next slide, Angie. So not only do you need to have a standard definition, but critical to know who's in your system in the first place, again, and to track prevalence change, you need to have universal screening and assessment with appropriate follow-up in jails. This is certainly a very critical area, very difficult in some communities to operationalize without additional support. But in terms of the state role, state could issue best practices. There's a lot out there on various tools and the validations behind those tools and source resources, could assess current adoption of best practices and could help accelerate adoption by either modifying existing standards, developing new guidelines, providing guidance on tools, processing, and also contracting is for third-party medical providers. This is also an area that's relevant for those conversations. Next slide, Angie. There's some state examples here, again, of states that have taken efforts and movement on this, some legislatively, some more through administrative policy. I've included both so you can get a flavor for the different approaches that states are taking in these examples. Next, we're going to move to ability to share information across systems. So if you move to the next slide, Angie. Again, as I said before, the Holy Grail is having some sort of statewide repository to facilitate this. It's very expensive and complicated. In absence of that, I tried to establish a few different ideas of things that could still assist in the meantime. We're working in Pennsylvania right now and have made a similar recommendation that they create a clearinghouse of sorts that is just a place for communities and counties and policymakers to come so they can have some sample resources all in one place, a standardized MOU, for example, sample data use agreements. Ohio's taken actions in that space. And also information on model communities. I don't like to use model, but let's say communities that could be information on how other communities can then replicate their efforts so they're not reinventing the wheel. And also model forums could live here, lots of other guidance. The guidance I mentioned earlier on third-party medical providers could live here, which is very, very critical. And just to have a place where you can find this information. And if the state were to develop guidance on information sharing that interprets both state and federal law, that would also could live in this space. If you go next, here's an example here. You can see Michigan developed a model tool to share, or a model form, a standardized consent form for sharing information across healthcare providers, or mental health providers. And then it has more information about Ohio developed guidance on information sharing, interpreting federal and state law. Last but not least, we've been talking about crisis a lot in general in this moment, and also, I'm sure in Georgia as well. I wanted to highlight one component of a crisis system. It, of course, is not limited to the crisis stabilization unit piece. There's also warm lines and co-response. But I wanted to highlight the crisis stabilization unit piece as something that communities have asked for and are creating, in an absence of dedicated funding, are having to do a lot of braiding and blending and financial calisthenics to make that work. I also wanted to highlight policies that can also create an environment that allow for a crisis response. So I highlighted two in particular for Georgia's consideration. Actually, if you can go to the next slide, Angie, if you please. Go to the next slide. There we go. So I have here, there's an example of Arkansas that created regional crisis stabilization unit pilots, and we can give you more information about how they did that. And they also enhanced their CIT statewide. And then Utah also just authorized more resources for these regional stabilization units to give police a place to take someone who's in crisis to reduce the reliance on costly ERs and on jails. Next slides. And here, these policies that are important to create that environment where you can actually access these centers and not just rely on ERs. Highlighting two in particular. The first is citation authority, and looking at the ability for law enforcement to issue citations instead of arrest. There might be some opportunities there for the state to support local application or to look at an existing statute. And then transport to non-emergency settings in Georgia. There's some things that the state could do, and I highlight some specific codes here that would allow EMS and other first responders to provide health services in the community and would allow them to take people to those non-emergency settings, which I also know is related to sort of liability issues and payment mechanisms on the back end on the administrative side. But those are creating the policy environment so that people can access those crisis services instead of those ERs and jails. And then last but not least, some other things I think we've been talking about telehealth. It sounds, and I think that I just want to underscore that. We've heard from many communities, it's hard to put the toothpaste back in the tube. This has just been such a helpful mechanism in criminal justice context. We've seen a lot of great movement on this. Expanding peer support services and health workers, particularly at reentry, but also just along the way to help engage people in care and treatment and to help coordinate services and to have those be even more community led. And then of course, housing remains a critical piece, particularly for people who have the most complex needs, and they may need something more intensive like permanent supportive housing to really help meet their needs and stop this cycling that they're experiencing. And I have some examples here on telehealth if you'd like to see a little bit more about how states, including I see Georgia has some guidelines that I wanted to highlight. And I think that's it. We'll end there. But thank you so much for your time today. And we're just so appreciative to be able to share a little bit more with you all, and very happy to answer any questions or as follow-up or now. I know we have not a lot of time, but we're here. Contact information was just displayed and we can share that as well.
Thank you. Thank you, Alex. Thank you, Angie. Mr. Chairman, that's the report. We're happy to answer questions, but in short, if you look at the work of CSG on the specialized caseload study that they're going to do at DCS, the recommendations to more properly identify, use a common definition, share information, and increase opportunities to connect to services are all very, very valuable options and recommendations that I suspect my committee will be voting on in more fulsome fashion here in upcoming meetings with specific recommendations for the full committee's consideration. So, Mr. Chairman, that's our presentation. Thank you for the opportunity to be with you today.
Thank you, Justice Boggs. I appreciate that. Appreciate the work you've done. You know, one of the couple of things I've noted that was highlighted is we hear a lot of times the statistic about the state prison system and the number of people who are in state prison with mental health issues. And our state facilities are doing a good job providing service, but most of the inmates are in the county jails because they're committing minor offenses, not typically misdemeanors, things that they're not actually getting into the state system. So our local sheriffs, our local police chiefs like Chief Deckmore and others are having to deal with those individuals on a reoccurring basis. One of the other things too, Justice Boggs, as we go forward into next year and beyond, one of the things AOT, what community supervision's doing and others is great. Mental health courts is great. But those individuals who suffer from the reoccurring persistent mental health issues like schizophrenia, bipolar, acute depression that are not going to ever get better, they're going to require care for the rest of their life. I'm not sure that anybody solved the riddle of how do you keep that person under some level of supervision really for their entire life if they fall into that specific category. And I think that's something we need to look at. I've had a personal example of a gentleman who I've told you before, mental health court, great mental health court participant, graduated, but then ended up being found deceased by his sister in a sleeping bag at their old home place, just because without that supervision, he would always go through the cycle of coming off his medication. So just something to think about as we move forward. And again, Justice Boggs, thank you for all your work.
Thank you, Mr. Chairman.
All right, next up is child and adolescent behavioral health. That is chaired by Dr. Vinson. Dr. Vinson, I want to tell you personally, I appreciate you taking the opportunity to speak with my daughter who's at Georgia that has an interest in being a psychiatrist. She told me after speaking to you, though, that she would like to speak to someone that was not a genius because she said after speaking to you and all the things that you did, she said, I can never be like her dad. I need to try to talk to someone who might be more my speed. So she was very impressed with you, Dr. Vinson.
Well, thank you. And I always enjoy talking to young people. And I was impressed by her too. And so what we'll have today is 3 presenters, 2 who are practicing in different areas of the state and 1 from the Barton Law and Policy Center. And so I'm going to ask Dr. Eric Lukowitz to go first. And he is an associate professor of psychiatry at the Medical College of Georgia at Augusta University.
I've had to click on things, so I appreciate. Now I can't. Can you see me?
Yes, we can see. Andrew.
Okay. And so I'm going to try to do things quickly because I know we're running behind. But Mr. Chairman and committee members and honored guests, I again appreciate the opportunity to talk with you all today about the benefit of a single Medicaid formulary. I've been practicing as child and adolescent psychiatrist in Georgia since 2003, and I've had the privilege of having testified about issues related to mental health issues before various committees of the Georgia legislature. I currently serve as an associate professor in the Department of Psychiatry and Health Behavior at Augusta University and as 3rd-year class dean at the Medical College of Georgia. Let me begin first by explaining the current state of affairs as it stands. In addition to Georgia families, Georgia contracts with 4 national current hold on, let me share my slides here. All right. Looking for the button here. I think this is it. No. I'm not as used to Zoom as I am with Teams. So let me find, do you know where the button is to share slides?
Should be on the bottom of the very bottom of your screen. Okay. With the green arrow.
There we go. So let me do this. Share. Okay, from the beginning. Can you see, is this showing as a slideshow or just the individual slides?
The slide is showing.
Okay, all right. So so this is me. Let me skip to the next thing. All right, so there are basically 5 entities that make up Medicaid in Georgia. There's the regular Medicaid, which is mostly for people with significant developmental disabilities and other medical issues, chronic medical issues. And then they contract out with these community management organizations. The first 3 were AmeriGroup, Peach State, and WellCare. And then about a year and a half ago, they brought on CareSource. So as a result of this, there are now 6 formularies or preferred drug lists. And so that's an issue because as a physician, if you write a prescription for someone for a drug that is not on the preferred drug list, they take it to the pharmacy and the pharmacy says they can't fill it. Now, sometimes the pharmacy will tell them you need a prior authorization, and sometimes they won't. And sometimes the pharmacy will call the provider and say, we need a prior authorization, in which case we can fill out some paperwork. But they have these specific hoops that you have to jump through. And sometimes it means that you have to prescribe certain drugs before others, and it's usually generic drugs. But and you have to fail one before you can get onto something higher up, and they call that step therapy. Anyway, so if the medicine is not on the formulary, they can't get it filled unless they pay out of pocket. As you well know, if they're on Medicaid, they don't have the money to pay out of pocket. And so after we fill out the prior authorization, sometimes, about half the time, they'll approve it, but other times they'll say to us that they need we have to appeal. So that requires us to write a detailed letter of the reasons for why we feel like they need to be on that particular medication. And sometimes they will approve it and sometimes not. And so during this time, it takes time from our ability to see patients because it's a tremendous administrative burden. And so if we're busy filling out these forms and writing these letters, we can't be seeing the patients. And as you've heard all day, we have a shortage of mental health providers in Georgia. And so this is another way to increase the shortage. Let me move on to I'm trying to keep my thoughts quickly here. So, all right. So the problem, so what if the physician simply prescribed the medicine that is on the formulary in the first place? The problem herein lies that each formulary is different, and what is on the formulary this month may or may not be on the formulary next month. In addition, patients are frequently moved from one care management organization to another, and without them noticing it or understanding why that happened. Sometimes it's because their services have been interrupted because they didn't send in some paperwork validating their income, but sometimes we just don't know. So they may have been on a medicine and stable for months and months, and all of a sudden they're told they can't get it. So the other thing that I want to tell you about, which I think is worth bringing up today, many formularies contain primarily generic drugs, which would be fine. However, the FDA, in their infinite wisdom, has decided that a generic equivalent of a brand name drug needed to contain anywhere from 80 to 125% of the bioavailability of the brand name. That means that if you have one generic version that has 125% of the bioavailability of the previous medicine, you go to another one, and pharmacies are always changing their generic drugs that they carry, and they go for the cheapest one. So you just never know how much you're getting. So sometimes you could conceivably get, 50% less of the medicine. So that complicates the matter. But it gets even more complicated from here. And so let me talk about ADHD as an example, because I treat a lot of patients with ADHD. And I'm sure that you wouldn't be surprised that Ritalin or methylphenidate is used to treat ADHD. And there's, not counting generic versions, there's actually 15 different versions. And this is what a prescription drug list or let me hold on. Here we go. This is the Medicaid formulary for Georgia Medicaid. And you can just see there's methylphenidate down here. In this instance, it says methylphenidate SA OSM. That's generic for Concerta. And it pays all except for this one brand. So it's pretty complicated. And it's hard to know exactly which one is available for the patients because it does change. Now let me move on to the next. So these are the versions of methylphenidate that are actually available. And they're all the same active ingredient, essentially. I guess technically dexmethylphenidate is a little bit different, but they're all the same medicine, but they don't act the same because the way they're released into the bloodstream really has a dramatic impact on how they work. So for example, there are liquids, there's immediate release tablets, which is the most common. There's liquids, chewable tablets. There's multiple forms of extended release tablets that each act different from the other. There's a transdermal patch that delivers medicine through the skin. There's even a drug that can be taken at bedtime and that kicks in the morning. As a clinician, a lot of time goes into the process of determining which medicine or combination of medicines will most effectively treat the patient's symptoms. And it can take months to get to that, to find a regimen that works for them. And so when a previously available drug is removed from the formulary, it can have devastating effects. And a few years ago, and I'll just use this as an example, WellCare decided to take Vyvanse, which was a commonly used long-acting ADHD medicine, off the market. And consequently, millions of patients that had been stable on it in Georgia were unable to get it. So that's an example of the disruption that can happen. And so when the drug is removed, they show up at the pharmacy. They may get a notice, but we get a lot of things in the mail and we don't really pay much attention to it. So in this instance, they go to the pharmacy and they tell them, we can't fill this unless you pay out of pocket again, which is never really an option. So just in case you wondered if that this was just the rantings and ravings of a mad child psychiatrist, as it stands right now, 8 states currently have a unified Medicaid formulary: New York, Louisiana, Texas, Missouri, California, Michigan, Tennessee, and Ohio. And Dr. Vincent will talk a little bit more about this at the end as she does her summary. In addition, I was contacted by some colleagues from the Department of Health Policy and Management and the Department of Behavioral Health Sciences and Health Education at the Rollins School of Public Health, which is part of Emory University. And they published a paper last year on the negative effects of multiple Medicaid formularies in children with ADHD in Georgia. Their conclusion was that the restrictiveness of the preferred drug list and changes in the preferred drug list on Medicaid plans lead to negative consequences for medication continuity and quality of care for Medicaid enrolled children with ADHD, as well as more burden for safety net clinics involving these use. And it's not just ADHD. I was working, doing some inpatient work about a week ago, and we had a patient who was not taking, he had schizophrenia and he was refusing to take his medicine once he left the hospital. So we tried to get a long-acting injectable, but that was, of course, was not on the formula. So we filled out a prior authorization request. It was denied. we filled out the appeal, and it took almost a week before we heard back. So the young man was sitting in the hospital waiting until he could get this long-acting injectable. So it has, you know, long-standing effects on patients and decreases the ability to keep these people stable. And with that, I could show you the paper, but I don't know if that's important given our time crunch. So I can take questions if anyone has them. I thank you for your time.
I don't see any questions. So Dr. Vinson, if you want to continue, and then we'll take any questions that do come up at the end.
Absolutely. And so next will be Dr. Kaylin Lane, who is the Medical Director of Unison Behavioral Health in South Georgia.
Hello, is everyone able to hear me? Okay, all right, great. Well, and when Sarah asked me to speak, I was certainly honored. And I sat down to sort of think about, you know, what did I feel like were the most important things to talk about? And obviously I'm not going to have time to cover all of the most important things, but I wanted to hit on 3 topics. I work in rural South Georgia. I actually live in rural South Georgia, but I live about 3 hours away from where I work. So I do almost all of my work almost exclusively by telemedicine. So I live in a small town in Southwest Georgia, and I work and see patients in a bunch of small towns in Southeast Georgia, based out of Waycross. So, and as I'm sure many of you are aware, I think the number one point I wanted to hit on, number one problem or barrier is supply and demand. I mean, I think we know that there is a significant lack of mental health services particularly for child and adolescent populations at all levels: outpatient care, inpatient care, residential treatment programs. There are just not enough services in general, across the board, across the state, across the country. Just to give you an idea of kind of the impact of this in Georgia, there are 6.5 million Georgians who live in a mental health professional shortage area. 6.5 million just in our state who live in areas that are designated as having a shortage of mental health professionals. On a national level, there's about 20% of US minors have psychiatric illnesses that require treatment. Of that 20%, only 36% actually receive psychiatric services. So obviously, huge problem, not enough resources, not enough trained clinical professionals. Going back to just on a state level in Georgia, roughly 77% of the counties in Georgia, so that's 122 out of our 159 counties, have no child and adolescent psychiatrist. I live in one of those. So technically there's one child and adolescent psychiatrist in my county, but I don't work here. So technically there's none. And there's none in most of the counties where I see patients on a daily basis. In Georgia, there are roughly 2.5 million minors, and 199 total child and adolescent psychiatrists. So that's basically 8 child and adolescent psychiatrists per 100,000 kids. And the average age of a child and adolescent psychiatrist in Georgia is 52. So I'm slightly under that, but I think that just sort of illustrates that, you know, our professional population, particularly amongst child and adolescent psychiatrists, is we're not spring chickens. So when you think about, you know, likely ages of retirement and that kind of thing, I think it just sort of further, you know, illustrates and escalates the urgency for trying to do something about what I view as a crisis. So supply and demand is one of, I think, the biggest things I wanted to highlight. The second thing is, and I've touched on this already, location. You know, geographic issues, distances that people have to travel to find services. You know, keep in mind that many of our clients, many of our patients live in extreme poverty and have no transportation or have very limited, you know, unreliable transportation, or they have to pay friends or family for gas to help, you know, get them to and from appointments and to and from therapy sessions, that type of thing. There's essentially no public transportation anywhere in South Georgia. So, you know, that's sort of not even a reality for those of us who live here. Of course, poverty also brings with it, limited access to technology, for example, for telemedicine services. And I could spend about an hour probably talking about just things that we've had to do with telemedicine since COVID to try to, keep taking care of our clients. But I won't put anyone through that. But limited access to technology, problems with internet accessibility, and also bandwidth problems, also interfere a lot with even the provision of telemedicine services, particularly if the services are being provided to patients who are, located in their homes at the time or in their vehicles at the time of the appointment. Of course, the difficulties with location can, I think, be partially overcome or at least improved by school-based mental health services and school-based clinics, basically. Many of my patients' parents can walk to their school, whereas they would have to, pay a cab or catch a ride to one of our clinics. So I feel like that could certainly be a help if we could expand and create more school-based clinics. And the other, I think, sort of key thing that I have become aware of in practicing telemedicine, and particularly practicing telemedicine in the schools, is that there's such better collaboration. With my students, my patients who are students, if I need to get information from the teacher is immediately available to me. I have a school nurse, if there's a concern about vital signs, who can recheck vital signs. If I need the school counselor or the special ed director or whoever I need to speak with to get information from or to ask questions of, they're so much more easily accessible when you're calling into their place of work. So there's a whole lot less phone tag that way. I'm trying to get collateral information. So that's just another benefit to school services. And then the other thing are just barriers to treatment. In the way of legislation. There are currently existing state and federal laws and rules and regulations that place restrictions on telemedicine services. And unfortunately, what were intended to be safeguards have turned into barriers to the provision of mental health services and other medical services via telemedicine. The restrictions have been lifted currently because of the pandemic. My hope is that perhaps this will shine a light on some of those restrictions and regulations that need to be updated and changed. And I'm hoping that will be the silver lining to the dark cloud of COVID. We're all sort of just holding our breath and waiting to see if or when those restrictions are going to be reinstituted. Every time I see a patient, they say, oh, are we going to be able to do the appointment like this again next time? It's so nice that I don't have to go into the clinic and worry about getting COVID. And I just tell them, we're going to keep doing it as long as we can, as long as we're allowed to. So I think certainly looking at that, I've personally had an experience within the last few years where I appealed to Georgia's Composite Medical Board in order to try to get them to amend one of their rules to bring it more in line, more into compliance with federal regulations through the Ryan Haight Act. And after a lot of blood, sweat, and tears, we were able to get that rule amended, but only with regards to the prescribing of stimulant medications for ADHD. So, pre-COVID, the Georgia rules are still not quite in alignment with federal regulations. And even the federal regulations were sort of in the process of being amended and edited and hopefully brought more up to date. So we're all sort of waiting to see what's going to happen now post-COVID with those existing regulations. So I certainly would be happy to answer questions if anyone has some or elaborate more on anything. I can talk all day and I will do my best not to.
Well, thank you very much. Just a question for you, since you practice and live in rural Georgia and rural South Georgia. we heard talking about workforce development, and I don't think we've had a single subcommittee that hasn't mentioned that as a real issue, and I think it is. But one of the things we talked about was loan forgiveness, like we have on the medical side for people who live or practice in a specific area where we show a need. Do you think, number one, would loan forgiveness encourage someone, a psychiatrist, for instance, coming out of school to come to an area to practice where we had a high need, or another clinician, depending on the level and the need? And then the second part of that question would be, do you have any other specific ideas as someone who practices in this area of things that would help us encourage the workforce to want to locate to rural Georgia and to the areas we have such a strong need?
Well, I certainly think the loan forgiveness is a great idea. And I mean, I think that certainly could be an incentive. I know, as medical director for Unison, I can say we've had a pretty good track record actually with J1 visa candidates. We've had some excellent psychiatrists who have come and worked with us, and sort of met that criteria in order to help get their visa, furthered along in the process. And so I'm sure certainly for non-visa candidates that loan forgiveness could only incentivize them to come to South Georgia. Again, I'm a native of South Georgia, so, that's why I'm back in South Georgia after having lived elsewhere for over 20 years. And so for people who don't have those family ties, those roots in South Georgia, I think a lot of times just some exposure to what small town life is like could be helpful. We at Unison, we host medical students. We potentially may eventually be hosting residents, but we're hosting medical students to try to not only expose them to mental health and what is psychiatry and what is this all about, because it's not one flew over the cuckoo's nest or anything like that, but just sort of really give them a sense of what working in mental health really entails, good or bad, so that they know what they're getting into. And then also, giving them a chance to actually live and work, even if for only a few weeks, giving them a chance to live and work in a rural area so that they can decide, is this something I have a taste for, both the profession, but also the lifestyle. I think you never know if you're going to like something or not until you experience it, I think. And, so I feel like, more opportunities even along those lines, maybe even for non-medical professionals as well, therapists, social workers, psychologists, clinicians of other specialties besides medical.
All right, thank you very much. Do we have any other questions before we move on? I don't see any. Dr. Vincent.
All right, so our last speaker is, thank you so much, Dr. Lane. And as her story illustrates the importance of having people from these underserved communities that get the opportunity to train and be mental health professionals, because when we look at shortage areas, the people who are from those communities are more likely to serve in those communities. So thinking about that in terms of pipeline. But wanted to have our next speaker, Mr. Parker Leckerling, go, and he is a fellow at Emory Law School's Barton Law and Policy Center.
Thank you, Dr. Vincent. I'm just going to go ahead and share my screen real quick.
Thank you. Is our plugin right there or up here?
Okay, can everybody see my screen?
Okay, that one is good.
Perfect.
Thank you.
Okay. So thank you, Mr. Chairman, members of the commission. My name is Parker Leckerling. I am the Law and Policy Fellow at the Barton Child Law and Policy Center. I'm here today to provide you with an update on the impact of COVID-19 on Georgia's child and family serving system.
Thank you.
Specifically the Division of Family and Children Services and the Department of Juvenile Justice. I'm just going to get through my presentation real quick, after which I welcome any and all of your questions. Just to lay a brief foundation, these public child serving systems frequently operate as de facto mental health systems. And this is due to the experiences of children at home and in their communities, like exposure to violence and other trauma. And as well as this is what you've heard from another number of other speakers today, the lack of community alternatives and access. So understanding the capacity and functioning, as well as the operation of these agencies is critical to your consideration of the state's response to the mental and behavioral health needs of Georgia's children. This update would have been challenging under the best of circumstances, which these are obviously not, though there are some bright spots to report. Unfortunately, the current pandemic, which in itself is unprecedented, has placed unprecedented pressures on these agencies and the children that they serve, and as well as the resources that are available to all of them. All of this at a time when those needs are definitely increasing. These systems really do represent the deepest end of the spectrum. There's, of course, important work going on in adjacent systems like DBHDD and the DOE, which are more universally relevant to this mission, as well as the composition of our safety net. I think when the director of the Barton Center, Melissa Carter, was here with you last time, I think she characterized this moment as hopeful about recovery. Our subsequent experience in the past few months has told us a lot more about the system's ability to endure. So starting with the Division of Family and Children's Services, DFACS. DFACS is responsible for both child welfare and related services, as well as the administration of public benefits. On March 23rd, DFACS closed their lobbies and offices. Staff have been teleworking ever since. Counseling services and parental visitation have been conducted on virtual platforms on the telehealth model, or by phone if technological limitations exist. Any service or assessment that requires face-to-face contact has been suspended. All staff have been instructed to make inquiries regarding the health status of caregivers or children before making any in-person contact, and that's regarding new child abuse and neglect reports. So DFACS, like most state agencies, endured some cuts as a result of the revenue shortfalls that the pandemic brought about. Fortunately, the original projected budget reduction of 14% was revised down to 10% in the final report. Funding was redirected to ensure that no local offices were closed. Furloughs were eliminated across the board. TAMP funds were used wherever possible to preserve programs and positions. All told, there was a little over $3.7 million in reductions for personal services, and that's mostly from the elimination of 49 vacant positions in child welfare services. So this is just a helpful chart. It gives you a pretty clear indication here of how COVID has affected the reporting systems in the welfare system. CPS reports have declined about 50% since the start of the pandemic. You can see that most significant drop between March 12th and March 17th. The public health emergency was declared on the 14th, and public schools closed on the 18th. Typically, we were looking at around 4,000 cases a week. Since mid-March, we're down to around 1,800 to 2,000. We are starting to see a little bit of a rebound now. But where you could really see that steep drop-off is from the closing of the schools. This is that same chart, but just referring to school administrators, school counselors, educators, and childcare providers. So you see how significant that drop was amongst this population. School counselors, for example, report maltreatment at about double the rate of any other reporter. And the majority of those reports now, just like they were before, are for neglect. And that's about triple the number of any other allegation of maltreatment. And to kind of juxtapose that chart, you see here the drop off in reports across all other sources. So yes, there was still a drop off, but you know, you can see that the closing of the schools really had the largest impact on where our reports were coming from. And then just to kind of further emphasize that point, you see every year consistently, there's a drop off around the summer when the school is out, or around the various state holidays. But then you see the drop off for COVID. So it's been definitely more dramatic, but we are still starting to see that uptick, which makes a lot of sense. Georgia's has been in the process of reopening. The schools are obviously both in person and virtual, depending on your locale. So we're having more of those contact points restored, but the numbers still haven't quite rebounded to the levels that they were before the pandemic. And then this is just to further emphasize that point. This is where all of our reports come from. where what the report is actually alleging regarding the maltreatment, and then the outcome. So you see here, educators, our medical professionals, and our legal professionals really do make up the lion's share of our validated reports of maltreatment. Family and friends who have been most in contact with children in these times, they still do absolutely make important contributions to reports of maltreatment, but they also do lack some of the advanced training and the sensitivity as these other professionals do. So that's just to further clarify that point. On the juvenile justice side, you heard Justice Boggs talk about DJJ a little bit before, so I'm not gonna harp on this too much. But just like DFACS, they serve a population of youth with significant mental, behavioral, and emotional health needs. DJJ has similarly experienced disruptions in providing services to this population. Again, just like DFACS, they were originally slated for a 14% reduction in their budget, and that was ultimately revised down to 10. Again, furloughs eliminated across the board. They did realize about a $15 million reduction in the elimination of vacant positions, and to incorporate some staggered start dates across the agency. And lastly, this is just kind of a number. You heard Justice Boggs again talk about the infrastructure in place regarding these the department. But these are the total number of cases as of, I believe this was October 26th, for the number of DJJ employees or youth who have confirmed positive for COVID-19. So you see, you have 237 total staff confirmed. That's about 176 secure facility employees, 46 service division employees, 12 DJJ central office employees, and 3 employees at other DJJ sites. And then 210 of those 237 have received medical clearance to return to work. And again, you see that total of 79 youth that have tested positive for the virus, and they've all received medical clearance to resume normal life in the facilities. What I think that these numbers tell you is you heard the populations before. Our DJJ has actually done a pretty good job of managing the virus in their facilities. You've heard a number of horror stories from adult correctional facilities across the country about outbreaks. They've managed their population pretty well, but that's come by and large from restrictions in services that they're able to provide to their youth and their care. So you're having to rely a lot more on you're having to rely more on email and video conferencing, as well as phone calls for visitation and care. Health screening has been mandatory, but visitors are all screened before they get access. You're still getting on-site mental health treatment, but off-site treatment options have been suspended. And they're still getting educational opportunities associated with their placement. But again, you're just seeing that same level of disruption with the DJJ as you did with DFACS. So a lot more work to be done. I hope this was a helpful update. I'm happy to take any questions if there are any, but that is everything I had for you today.
All right, I know we have one question, I believe, from Dr. Johnson.
I'm fine. Thank you, though.
All right, thank you. Any other questions? All right, if not, we will turn it back over to you, Dr. Vinson.
All right. So I will wrap up just with some recommendations and a very, very brief overview. I will not be before you long, as the Southern pastors like to say. So I just want to thank Dr. Lane, Dr. Lukowitz, and Parker for sharing with us today. And these are just some quick recommendations based on what we've seen. And so I just want to talk about sort of the key why and what those recommendations are. And so of course, today we talked a lot about crisis, and we let out talking about access in hospitals and ERs. And there absolutely is a question of what to do about children in crisis. And it's one that is compelling and that it makes sense that we ask. But the question is, why are there so many children in crisis in the first place? And that is really where we want to intervene as We think about these children and adolescents as members of our communities, as members of our families, and as we think about the best way from a public health standpoint and from a treatment standpoint to help them. And so when we think about what children need from a mental health standpoint, foundation is critical. So having a true home with housing stability, food security, having their basic needs met, a reliable caregiver, meaning a consistent, available adult who can instill a sense of worth and advocate for the child, that provides educational opportunities in the community where there are safe schools and prep for the things that they need, and healthcare access if and when they need it, are all really important when we're thinking about why and how we can prevent so many children from ending up in crisis. And one of the things that affects that pipeline is child poverty. And in our state, it's a really significant issue, and even more so in rural areas. And we've brought up issues of access in rural areas in a number of the presentations today. And that's part of why I wanted Dr. Lane to share her perspective as someone who is on the ground floor there, because I think sometimes it's overlooked in our discussions and our conversations, but it actually affects a higher percentage of children in rural Georgia than in urban Georgia, with 33% versus 21%. And when you compare our state on measures of childhood poverty, childhood health, we come out 44 out of 50. And so when that's the case, those things that are needed for foundations are compromised. So you have things like housing instability and food insecurity, caregivers who can't get the mental health care that they need. And so since they're poorly supported, they can't give their children what they themselves do not have, unmet educational needs in their local communities. And the part that I think we can do something about even now is the limited access piece. And there are sort of the big picture things to do that, but there are things that could be implemented on a more incremental basis to make things better. And what families experience and what we've heard about today are gaps in coverage and capacity, workforce deficiencies, and administrative hurdles. And so thinking about ways that we can address those things. So we want to think about upstream, and we know that we could use more crisis units and we could use more child, insert the blank in terms of mental health professionals, but we have systems in place, we have some people in place, but there are missed opportunities for intervention upstream that we could really try to optimize in order to better serve the youth in our state. And those places where kids already are, where there's already some infrastructure and professionals, are things like your primary care visits, thinking about community-based care. And for a first step, my recommendations would be an approach where we optimize what and who is already in place, and that we do that in a way that provides us with the greatest geographical reach and that helps children across the mental health continuum. So not just those ones who are in crisis and who are in that very severe range, but getting to those other ones before they get to that level and thinking about what can have a bigger population impact and will also reach children throughout the state. And so I asked Dr. Lukowitz to talk about the Medicaid formulary, because Medicaid is a really big player in children's health in our state. So 1.3 million children in Georgia relied on it at some point in fiscal year 2016. 76% of children living in or near poverty are served by public coverage. And because of those things I just shared with you, those children are a higher risk population for having mental health problems. And 70% of all Medicaid CHIP enrollees in Georgia are children. And Medicaid covers 3 out of 8 children in Georgia. So if you address issues with Medicaid, it's going to help a significant proportion of children. And so that unified Medicaid formulary is something that really has the potential to reclaim precious clinician time when you have under 200 in the state, and we're using child psychiatry as a proxy for mental health professionals, period. We're understaffed across the board. You don't want people using their time on things that actually don't help the mental health of Georgia's children and that don't pay off in that way. And I've had conversations with people who have successfully implemented this in their states. And one of the things that they emphasize over and over again is that it allows cost savings to the state because there's a bigger volume discount. So instead of 5 different people bargaining with pharma companies, the state as a whole can do it, which gives you more leverage, which gives you lower prices. It also gives the state more transparency about prescription drug costs, which is also a win when we're talking about data and being data-driven in terms of how we approach these issues. And this is just a quotation from a child psychiatrist who was instrumental in that transition in Louisiana, who said a single formulary really helped us in our practice. And as Dr. Lukowitz mentioned, a number of states have put this in place. And so recommendation 2 relates to primary care providers. And so as Dr. Lane mentioned, there are a number of counties in Georgia that don't have a single child psychiatrist. And again, the focus is not child psychiatrists. We're using that as a proxy for the fact that they don't have the mental health services, period. If you look at that map on the bottom left corner, the gray counties are ones that don't have a single person. The red is severe shortage. The yellow is high shortage. There is a color for sufficient, but none of the counties in our state meet the criteria for having a sufficient number of providers. So with that in mind, we could open 6 child psychiatry training programs tomorrow. It is not going to help us meet the needs of the children in our state. We're going to have to rethink the way that we deliver care. And when we look at how our state compares to other states in terms of workforce, we're at 51% when it comes to child psychiatrists compared to other states. But with pediatricians, we're at 85%. So we're still not at average, but we're much closer with the pediatric workforce than we are with the mental health workforce. And so integrated care allows for those people who are in place, who are parts of communities, who already know families, to get additional support around providing mental health interventions early, where they can have a bigger impact and where they can help prevent people, children and adolescents from going into crisis. And so recommendation 2 is that we sustainably support integrated care by primary care providers. And one way that we can do this is by using integrated care billing codes. So these were introduced in 2017 by the coding system. So there are codes for things like, if Dr. Vita Johnson calls me and we talk about a patient for an hour, right now, neither one of us can get paid for that time, even though it's something that is directly relevant to the well-being of a child and is instrumental in their care. And so what that does is it makes it hard for people to do that on a regular basis because it's not sustainable, because that's lost time. We have these codes that are available to us. As a state, we have not chosen to pay for those codes yet. So the recommendation would be that we pay for those integrated care billing codes that allow for the psychiatrist to collaborate with the social worker. And that will allow for more collaboration across counties and across the state for telephone and internet consultations and for doc-to-doc consultations. And one of the other great things about integrated care is that not only are you providing resources and interventions for that child in that moment, but what studies have shown us is that over time, the pediatricians who are on the receiving end of that grow in their competency and in their confidence around mental health intervention. So they end up doing more mental health care as well. And then, as Dr. Lane mentioned, school-based behavioral health services, school-based health centers, and the Georgia, and I'm adding the Georgia APEX program. And when we think about, that previous map and then look at this map, we can see that Georgia APEX programs are more widely distributed throughout the state. They prioritize Title I schools where you're going to have kids who are at higher risk for mental health issues. And 60% of our school-based health centers are in rural areas. And so recommendation 3 would be that we fund and expand APEX by increasing the number of schools served, including more providers from the community and developing more peer-to-peer supports in that setting. And then recommendation 4 would be that we sustain and support school-based health centers because, as other presenters have noted, issues of transportation are a significant challenge, but we have schools already in communities. So if we have this as a hub for treatment and for care, it can not only be a useful place for children to receive mental health interventions, but these health centers also play a really important role in addressing the social determinants of health, which we know have a significant bearing on children's mental well-being. And I will stop there and see if anyone has any questions.
Yeah, just I've got one. I think we may have another one or two from other folks, but the formulary, the Unified Medicaid formulary, who makes that determination? Who's responsible for making the decision that we're going to have that in Georgia?
And so it in speaking with how it's been tackled in other states, it ends up being a collaboration between the state Medicaid agencies and payers and deciders, but also with the CMOs. And so you have to have everybody at the same table to decide on this. And it is a process that is absolutely going to take time. And in New York, for instance, they ended up allocating 1.5% of that budget, understanding there's going to be administrative costs associated with sort of rolling this out and hammering out how this is going to look. And so you would need a combination of state agencies and also representatives from the CMOs in order to do it.
And then the suggestion on community, or the question on the integrated care, primary care provider, integrated billing codes, that decision, I'm assuming, would be the Department of Community Health. Is that correct?
That's my understanding, yes.
Okay, thank you. I think it's important for us to understand, number one, what can we do that's going to require legislation? Number two, what can we do that would be maybe at the governor's disposal, for instance, through executive order to direct one of his executive agencies to make a change? And then number three, what is really outside of just one entity's control that's going to require some coordination? So that's helpful. So I believe we've got a couple of questions from folks online. Dr. Johnson.
Thank you. Dr. Vinson, thank you. I appreciate your comment that no matter how many child psychiatrists we train, that's not going to be the ultimate solution. Gateway here in Savannah, we did submit this week an application for an accredited child psychiatry training program. We've been working on it for about 2 years. And what we found, and I'm wondering if you've got some insights about this or what's true statewide. What we found is that family practice at the family medicine residency is eager to have embedded child psychiatrists teaching family medicine docs how to do it. But pediatrics honestly has not been. We've approached them several times, and it's kind of a surprise, and it's okay. Do you have any insights about which primary care physicians are open and what the reasons might be?
Well, I would say that's not my experience. I found the pediatricians quite open, and in fact spoke at the Georgia chapter of the American Academy of Pediatrics meeting a few weeks ago about COVID and anxiety and depression. And so maybe that's an individual provider thing, but I would say in general, our pediatricians really are standing in the gap, and they have welcomed resources and collaboration around providing care because they've been sort of left with doing it. And my experiences have been that they've been very receptive.
We would appreciate just the Department of Pediatrics here at Memorial. Maybe you could help us come at it from a different angle. Thank you.
Dr. Vinson, following up to that line of question, one of the things that I know that we've talked about, that's been talked about, is the concern of a primary care physician acting too much like a psychiatrist and maybe medicating or over medicating people for depression, for instance, and when they need to be in more long-term care with a mental health professional. How do you balance the need to integrate and to provide that type of care throughout Georgia at the primary care level, in pediatrics, for instance, but at the same time, not trying to have maybe a doctor who's not specifically trained in mental health issues to the extent a psychiatrist would be overstepping and taking on long-term care that should be left to a different doctor?
Absolutely. So, the reality is they're already doing it. They're just not getting support to do it. And so what we want to change is the level of support they have, because, we looked at that map and it's just full of gray counties. And so, and I call myself a pediatrician groupie. But, if they see a child in need or that they think they can help, they're going to try to do their best with what they have. And I don't think there's going to be a time when they stop trying to do that. So with that in mind, and given sort of who's in place, rather than trying to sort of limit what they're doing, we want to give them more support so that they can do it in a better way.
All right, good. Thank you. All right, next, I think we have a question from Dr. Fitzgerald. Dr. Fitzgerald.
Actually, I had a comment. And that is the new ECHO system that is being implemented in Georgia can have Dr. Vinson be the mentor to lots of people all over the state. So we have an ability to expand the knowledge we have and not just like give a lecture, which is like typical telehealth, but have a mentorship program. So like there can be back and forth, there can be like weekly meetings with a Dr. Vinson type who knows how to do this, that can impart that knowledge to the people who are already in South Georgia. Like she's talking about, the pediatricians or the family practice people that want to do stuff. So this ECHO program can help them go to the limit of their knowledge and then have a rapid feedback with Dr. Vinson to say, okay, now what do we do? So I think that is it is an expansive provision of it doesn't give a child psychiatrist there. That there's no child psychiatrist that's going to move to Ludowici because of that. But the doc, the family practice doc or the pediatrician in Ludowici can learn from Dr. Vinson with this ECHO model in order to help a majority of patients who live there.
So, and just to be clear, ECHO is one model of integrated care. And so it's in line with what I recommended in terms of those integrated care billing codes so that it can be paid for and sustainable so that we can keep doing it once we start doing it. And so, that's one piece of it, but it's in line with what I already said around being able to pay for the time that goes into a model like that. And certainly we've had different states that have had, phone consult programs and ECHO and things like that. But I see as the preliminary steps to that is having a way to have that billed for so that it can be sustained and we're not reliant on grants or things that are time limited or that are going to run out, because we want to do this in a sustainable way.
Exactly, which gets back to that thing we were talking about two people being paid for taking care of the same patient on the same day. So, which would require, it's a federal law, but like Georgia can apply for a waiver so that if I am in Ludowici and I have a patient and I need Dr. Vinson to help me manage that patient, both of us can get paid, which means it's sustainable.
All right, thank you. Any other questions? I don't see any. Dr. Vinson, thank you very much for you and your subcommittee's work and all the presenters. Thank you. All right, that concludes our presentations. I want to make some closing remarks. First, though, we'll ask our expansive audience in the crowd if there's anyone here that would like to make a public comment. Seeing none, get in line if you do, but seeing none, we'll move on. Is there any of the commission members that have any remarks or closing comments before we finish up? All right. Well, as you can see, we've had a lot of people doing a lot of work. I want to personally thank the subcommittee chairs and the members for working throughout some difficult times. It's been very impressive. I've been involved in some form of government for almost 31 years now, and here at the General Assembly for some time. And I asked Representative Oliver, and she agreed, this is probably the most expansive amount of information at any committee or commission meeting that I've ever been involved in. So a lot of work, and I appreciate that. And I think the public understands how serious you all are taking this. I'll be getting with the subcommittee chairs to set up a meeting to talk about all your recommendations as we start to formulate a report. We will also be meeting with Commissioner Fitzgerald department to talk with her as we formulate a report. We will probably then have a Zoom only commission meeting just for the purpose of approving a report for the year. Before we have that meeting, we will send the report out so folks will have time to review that ahead of time. So if you have any questions on that, you can let us know or talk to your subcommittee chairs. Yeah, also, if you were a presenter today or a subcommittee chair, if one of your presenters has not sent the presentation to Chelsea, please email that to her today. She plans to email out all presentations to all commission members today. And also all presentations will be posted online. So you'll be able to have access to those. All right, with that, if there's nothing else, thank you again for coming, and we are adjourned.
Thank you.